Thank you. And thank you to everybody again for participating. We had a great morning session. And I'm delighted to introduce Dr. Julianne Sosa, who is the Leon Goldman Chair, a professor and chair of the Department of Surgery here at UCSF. She also holds an appointment in the Department of Medicine and is faculty in the Philip Lee Institute for Health Policy. Dr. Sosa came to UCSF about 3 years ago from Duke. She's a world-renowned leader in endocrine surgery with a specific focus both in her clinical activity and in research in thyroid cancer. She has NIH and FDA funding and has more than 300 peer-reviewed publications and 80 book chapters, all in the areas of outcomes research, healthcare delivery, hyperparathyroidism, thyroid cancer, and is very involved in clinical trials. Dr. Sosa has so many different distinctions in terms of leading national and international societies that it's too numerous to mention. And I'm delighted to welcome her to the Harrison Symposium. So Julianne, please, thank you.
So thank you so much, Dr. Lee. Good afternoon. And welcome to the second half of the day and the third annual Michael R. Harrison Innovation Symposium. I'd like to thank Dr. Lee and the organizers of the event for the privilege of participating. I definitely admit to feeling like a bit of an interloper as an endocrine surgeon and surgical oncologist surrounded by so many revered pediatric surgeons. And maybe, frankly, a little bit of an imposter amidst a virtual who's who of science and innovation in the world of fetal surgery, along with a Nobel Prize laureate, Dr. Robert Grubbs, and social media icon and diversity and equity advocate, Dr. Esther Choo. What an agenda that has been assembled. Today brings together, I think, many things that resonate with me as a committed academic surgeon, surgeon scientist, and chair of UCSF surgery. The first is that today is a celebration of innovation and discovery and the primacy of science as the engine for surgery, medicine generally, as well as public health. If the pandemic has taught us anything, it is that scientists and physicians have an essential role to play, and evidence is the underpinning of the wisest policies. Today, we have seen and will continue to see science performed at the highest levels to assure that as physicians and surgeons, we are contemporary and maintain the agility to pivot and address public health issues in real time. For forever, UCSF Surgery and its faculty, learners, staff, alumni, and collaborators has placed science on the highest pedestal. As other academic departments of surgery have necessarily cut corners when it comes to research and education due to financial hardship and a paucity of funding, we at UCSF Surgery remain absolutely committed to supporting science and training the next generation of scientists. We believe in scholarship and generously resource scientists and science at every level. So today we will see current faculty as well as alumni of UCSF Surgery and mentees and trainees of Dr. Harrison, who tackle controversy and change practice in a durable way, armed with evidence and courage. Which brings me to Dr. Harrison himself and Dr. Harrison's legacy, which is measured not just by publications, inventions, reports, and patents, but by a generation of fetal surgeons and scientists who are transforming the field. including Doctors Tom Crummell, Diana Farmer, Dawn Nakayama, Scott Adsick, Ellen Flake, Craig Albanese, Mike Longacre, and our own Tippy McKenzie. Dr. Harrison is indeed an inventor. For those of us outside of pediatric surgery and pediatrics looking in, we know Dr. Harrison as the inventor of fetal surgery. But through his mentees and legacy, he continues to actively transform the field, to include the artificial placenta, catheter-based treatments, and molecular and stem cell therapies. Dr. Harrison, you represent the very, very, very best of UCSF surgery, past, present, and most important, future. Thank you for being a trailblazer and inspiring the next generation of thought leaders and beyond. I am excited to be in the audience today and frankly, every day. Thanks so much, Dr. Lee.
Thank you, Dr. Sosa. And before we start the afternoon's session, we have a video presentation that we'd like to show our audience prior to our very, the incredible scientific program that we have, as well as keynote speeches from Bob Grubbs and Esther Choo. So if you could cue that up, Denora and or Usha. And before we go on, I would just like to thank all the organizers, but particularly Denora and Usha, who have done just an unbelievable, spectacular job of organizing and getting all the luminaries here together. And I'm just incredibly appreciative of all their hard work and dedication. And to all the people who are talking and on panels and presenting today. So thank you.
I first met Dr. Michael Harrison in 1991. We exposed the hand, which was maybe the first time it had been shown on video.
When I think back on my days as a trainee and a junior faculty member with Mike, what I can say is that there was no better Pied Piper for pediatric surgery and for solving the problems of babies before birth than Mike Harrison.
I have had the incredible honor of having been a work partner to Mike for longer than anyone else. And through this relationship, I've learned so much. There is not a box that has ever been built that can contain him. He is always thinking and living outside of the proverbial box.
Mike's a classic storyteller. He imparted that on us, I think, through presentation skills and training us to give presentations in the Mike Harrison style. I'd spend hours putting my perfect presentation together, and I'd come in and present to Mike, and he would absolutely rip it to shreds, and he'd rearrange it. He'd remove most of the verbiage. He would insist that I not use more than a 3-syllable word anywhere in my presentation. He would insist that you tell a story. There has to be continuity and a story in your presentation, and he would tell you to pick out the dumbest looking guy in the audience and try to convince him of your arguments. And so I still, to this day, do that. So Mike, thank you for imparting a little bit of your storytelling ability. It's just a beautiful thing.
He made everything fun. There was never an idea that was too crazy. And he always found a way to support all of us. They were fabulously fun times. One of my favorite memories might be not directly related to the lab activity. It became a lab tradition to have a blind wine tasting, because after all, we were in wine country. One thing we learned was some of those inexpensive wines were just as good as some of those fancy wines. That was one of the most important things I might have learned in the lab, Mike. at least the one that served me the longest.
Dr. Harrison was definitely involved in technology and cutting edge technology at that. He worked with NASA using space-age shuttle technology to find a way to monitor the fetus while still in the womb after the surgery. Really quite incredible. On the other side of that, Dr. Harrison worked with a number of engineers and technicians and tool makers in the basement of the Parnassus Institution, where they used lathes and drill presses to build a whole variety of fetal tools that didn't exist until that point. Later on, he became very interested in magnets, all different kinds of magnets, cow magnets, magnets that were in liquid, magnets that were chips, and he used them for a variety of different things. He became interested in how to use them to treat kids with sunken chests, how to use them to deal with different kinds of anastomoses that were not successful until that point, and to deal with a way of treating sleep apnea. Dr. Harrison enjoyed working with young people, with engineers, with technicians, always stretching the envelope in the development of new technology. I would sort of equate him to a Winston Churchill who had about 100 good ideas every single day, and at least 4 of them could change the world.
Beyond the obvious creativity and intelligence, there are 4 things that I have seen that I've had such admiration for. The first is his hard work. None of the intelligence and creativity would be worth a darn without the hard work that typifies every part of Mike's life. The second is collaboration. People from all different backgrounds and from all over the world flock to work with him and learn from him. And through this collaboration, there's been so much that's been generated that has helped children and families from all over the world. The third is how joyful and positive Mike is in everything he does. He only puts effort into things that are meaningful to him, and who could argue with his choices? Family, friends, the health of children, the health of pregnant women, and advancing medicine through research. I was at lunch with Craig Albanese at Diana Farmer on a beautiful Bay Area day, outdoors at a cafe. Mike rolls in with blood-covered scrubs and sits down and starts immediately eating whatever food was on the table and says, "Sorry, I'm late." I asked how he was doing and what he was doing, and he said, "Oh my God, just had one of the hardest cases ever, a terrible gastroschisis with matted bowel and multiple perforations. Took me all night, but I think the kid's gonna be great." And then he finishes with, "Best case I've ever done." How many times have we heard this from Mike after surgery, after research, after teaching, after building something? Finally, the last thing I want to talk about is mentorship. All of Mike's accomplishments get amplified by him sharing them with others and then teaching them how to effectively make progress in whatever it is that they're doing. Mike, for being a great surgeon, researcher, educator, friend, and mentor, thank you.
Well, my name is Marcelo Martinez Ferro, and I'm a pediatric surgeon here in Argentina. When I finished my residency, I was really looking for a mentor, and I really wanted to know this famous surgeon called Michael Harrison, who was working in San Francisco, and he was an innovator, an entrepreneur, somebody that was changing the world with fetal surgery. I really wanted to meet this guy and learn from him. So I applied for a rotation, and to my surprise, I was accepted. And in July 1991, I arrived to UCSF Medical Center. I was in front of a man that was completely different from the rest of the men that I usually met in my life. Mike was somebody that had a lot of talent, surgical skills. He was a very modest man. He was honest. He was passionate. He had a huge proactivity. He was always optimistic, and he had a great perseverance. I noticed that most of his innovative ideas were not always supported, and that he was following his heart. So then 10 years later, Mike had a sabbatical, and he came to Argentina to spend it. So of course we made him work a lot. In just a few months, his leadership is so amazing. He established a team, and that fetal team still working today. And in 2001, we could even perform a fetal surgery in Argentina that was a landmark for the whole region. And it was like a start point for a lot of changes in all our country and all the rest of South America. Some other doctors from different parts of the world came and visited us in Argentina, but Mike was the only one that had such a fast adaptation to the Argentinian culture. He became a perfect and master of cook asado. And also, this is the only guy who's an American that I know that he enjoyed drinking mate. And you could go to his office at the hospital and he was always sharing the mate with you. And that was just so amazing for us. Of course, Mike and Gretch became a tango dancing couple and they were so good and we still miss them. And those were so good times. And, you know, I always said, how could it be that Mike adapted so well? So when he was here, I just took a sample of blood from the hospital and, you know, we processed it in our electron microscope and to our surprise, and this is what we got as a result. You know, that we realized that Mike has Argentine blood running through his veins. So you understand that this is a joke, but just wanted to tell you, Mike and Gretch and all the family, that we love you and you made a huge change. I learned from you to make the impossible possible. And so your legacy changed the life of thousands and thousands of people here in South America. Thank you so much. And we really love you all, guys.
Hi, my name is Valina Lipsky, and I was a patient of Dr. Harrison's 26 years ago. I was 8 months old and I came into UCSF for an emergency surgery. During that surgery, they discovered a tumor that was almost half my body weight. It was connected to almost all of my vital organs. And I actually recently read Dr. Harrison's 8-page surgical report, which details how when he removed the tumor from my heart had holes in it and blood was just pouring through those holes. He said it was a very stressful surgery and that it was a miracle I survived, but I think it was less of a miracle and more of a testament to his excellent surgical skills. Thanks to him, I am a 26-year-old nurse working in New York City on a bone marrow transplant unit. And I just want to say thank you for all that you do. And because of you, people like me get to go on and live their lives.
Wow.
Well, Mike, a few words before we start our afternoon session that you're going to help lead.
I don't know if I can talk. I'm crying. That was a beautiful, beautiful thing. Beautiful. With all those wonderful people and that wonderful patient. Thank you, Hanmin. Thank you, Usha and Denora and all those who worked so hard to put that together.
Well, it was definitely a labor of love, Mike, and thank you for all you've done for so many people. And we'll allow you to catch your breath for just a second, but we will start off with the session on Magnamosis with you and Lauren and Oliver and Rusty, talking about esophageal atresia and some of the innovative things that all of you have been doing. So Lauren, maybe you can kick it off for us.
Yeah, perfect. Can everybody see my screen okay? Perfect. So I guess we can start with introductions. I'm Lauren. I'm one of the second-year clinical innovations fellows with Dr. Harrison in his lab. Dr. Munster, you want to introduce yourself?
Yeah, hi, I'm Oliver. I'm a pediatric surgeon in Munich. Spent 12 years of my life in the States, but now am privileged to sort of be the transatlantic liaison to this consortium, and it's fun. It certainly is fun.
And Dr. Jennings, you want to introduce yourself? Maybe. Oh, maybe he'll join us in a minute. And then Dr. Harrison, you just got quite the introduction, but do you want to say anything to kick things off? And then I'll go ahead and give a little intro.
No, I'm just excited to, well, first of all, I'm excited to be with the people I like most. And to see all these people from the past is just wonderful. So I'm glad I don't have to dry my eyes anymore. Go ahead, Laura.
Great. And I see Dr. Jennings there. Dr. Jennings, you want to give a little intro?
Yeah, hi, I'm Rusty Jennings. I'm the director of the Esophageal and Airway Treatment Center at Boston Children's Hospital. And I've learned so much from Mike over the years, and it's really a privilege to be here.
Perfect. So the way that we've structured this is I'm going to go ahead and give a little bit of an overview for the first 20 or so minutes with Dr. Munster. And then we're going to open things up for the panel. So if you guys could go ahead and put questions into the Q&A box, I'll go ahead and read those questions off and we can direct them to the panelists as they come in. So we are going to talk today about using mini magnamosis for esophageal atresia. So just a little bit of background for the non-medical folks in the crowd today. Esophageal atresia is a congenital malformation that occurs in about 1 in every 4,500 live births in the United States, a little bit more frequent around the world. And it's a malformation in which a baby's born with their esophagus in discontinuity. So the top of their esophagus doesn't actually connect to the bottom of their esophagus. There's 5 types. That depend on the variation of whether or not there's a connection between one of the pouches of the esophagus to the airway as well. In about 45% of esophageal atresia cases, which is actually a little bit higher than we initially believed, is considered a long gap, which means that there's a significant amount of distance between the top pouch of the esophagus and the lower pouch of the esophagus. When we go and repair this surgically, really there's 2 main tenets of that repair. One is to establish esophageal continuity by connecting the 2 pieces of the esophagus together. And the second is to ligate the fistula if it's there, which is the connection between the airway and the esophagus. And, you know, while we've made significant progress in being able to repair this, morbidity after this repair remains quite a significant challenge. And really that comes from 2 places. The first is the surgical approach. In order to repair esophageal atresia, with the open approach, you need to do a thoracotomy, which requires a fairly large incision across the side of the chest. And recent publications have actually shown that after thoracotomy, there's pretty significant morbidity of about 25 to 60% rate of complication related to musculoskeletal malformations that occur after the thoracotomy incision has healed. Now, in 1999, thoracoscopic repair or minimally invasive repair became, was kind of hailed as the solution potentially to those chest wall morbidities related to thoracotomy. But unfortunately, it was found to be really quite difficult technically and had a significantly steep learning curve, with some groups reporting, it took 5 to 10 years to really learn how to do this repair. So what that's resulted in is a significantly limited adoption. And in a study that came out looking at the Midwest Pediatric Surgical Consortium, still showed that about 91% of repairs are still done open today. The other area of morbidity after repair is related to complications of the anastomosis. So in 1990, publications were stating that the overall rate of complication was about 65%. 21% of complications occurred due to a leak at the anastomosis, and 42 to 44% of kids would develop a stricture at the anastomosis. Now, since then, we have done a significant amount of research as a field in pediatric surgery. We have looked at surgical technique, whether or not to put a tube across the anastomosis after it's been repaired, acid suppression, prophylactic antibiotics, et cetera. But when you look at studies that were published in the last couple of years, we actually haven't even started to make a dent in the complication rate related to that anastomosis, which when we started to think about it, really suggests that maybe there's a better way to go about repairing the esophagus other than the hand-sewn way that we've been using. So we started to think about magnetic compression. So obviously this has been, vetted in esophageal atresia previously. The first reports were back in 2009, and they've continued to come out. And that's really been based around a device that was developed by Cook Medical called the Flourish device. They had actually got their humanitarian device exemption in 2017 based on about 20 or 16 patients, 5 of which were emergency use applications. They didn't have any leaks, but the data was actually significantly limited, or their results were significantly limited by a really high stricture rate of about 81.3%. And of those strictures, several of them became, or a significant portion of them became recalcitrant, and several of them actually required more invasive interventions such as surgical revision. More recent publications on long-term outcomes from that device actually demonstrate that 54% of patients that the device was used in developed recalcitrant stricture. And again, several patients required reoperation. Now, we sought to, based on, all of Dr. Harrison's previous research in magnetic compression, sought to figure out how we could improve upon, what we could learn from the Flourish device. So the indication from the Flourish device is really to lengthen atretic esophageal ends, again, the long gap segments, to create an anastomosis. Kids need to be under the age of 1, and the atretic segments need to be less than 4 centimeters apart. It uses a bullet-shaped magnets that are in a convex orientation, which you can see on the right side of the screen. The bullets are 6.35 millimeters in diameter, but actually at their mating surface, because of the bullet shape, the mating surface actually is only about 3.33 millimeters, which comes out to about 6 French. They're nickel plated on the surface. They do require a G-tube, and they do need to be removed after a period of time. They don't naturally release from the anastomosis around them. Now, I'm sure as a lot of people here already know, Dr. Harrison's been working in magnetic technology for a long time. And for the last 15 years has been developing the use of what was first called the Harrison ring to do magnetic compression anastomoses in the GI tract. The first set of rings were 23 millimeters in diameter. They had rare earth neodymium iron boron cores, and it were in a polycarbonate casing. Over the last however many years, lots of animals have been completed, over 110 pigs and 15 primates at this point. We've done 5 patients during a first-in-human trial that was completed at UCSF in adults in small bowel anastomoses, and then 3 additional compassionate use cases with the larger magnets as well. Now, what we sought to do was take that very well-vetted design of the larger magnets and minimize that or shrink it, while maintaining all of the essential design features that have been so well vetted in the larger version of the magnet. We also sought to, kind of had 3 specific goals. One was to democratize thoracoscopic repair. If we could make a more technically simple way to complete the anastomosis, could we then allow greater adoption of thoracoscopic repair and start to mitigate some of that morbidity that you see after thoracotomy? The second was allowing for endoscopic placement. Specifically in kids that if you're not already in the chest doing an operation, could you then allow for an anastomosis without having to complete a major operation again, and potentially avoid second and third surgical interventions in kids? And then the third, and the most significant as well, is to improve anastomotic outcomes. Could we potentially mitigate some of those complications seen around the anastomosis, like leak and stricture, that are associated with a hands-on anastomosis? So the product is a disc-shaped magnet with a convex concave mating surface. That mating surface is curved such that at the center of the device, you apply the most pressure to the tissue, and laterally towards the peripheral of the device, you actually apply much less tissue. And what this does, it actually limits necrosis or contains the necrosis of the tissue just at the center of the device to protect the perianastomotic tissue from any undue inflammation or anything like that that might promote the formation of stricture. They're 8 millimeters in diameter, so the mating surface is much larger than what we saw with the Cook product. And they have a gold plating on the outer surface. There's about 15% of the population that has an underlying nickel allergy. And so to add that last inert layer was really intended to minimize as much inflammation as we could. And then again, the product spontaneously releases from the perianastomotic tissue such that you're not inadvertently disrupting any kind of anastomosis. It's going to release once the anastomosis is physiologically mature. We've completed 2 preclinical studies to date. The first really looked at short-term outcomes. It was in 12 piglets. We did a staggered sacrifice, and what we found from that was that the magnets really tended to detach from the anastomosis around 8 to 10 days. We found that the anastomosis was mechanically robust with a high burst pressure. We didn't have any leaks. All the anastomoses were patent. And what we thought was most exciting actually was that on histopathology, we saw early neoepithelialization, which we hope or we believe is going to be protective against stricture. These are just some cool pictures from those pig studies. And then we also did a second preclinical study looking at long-term outcomes. We looked at 10 piglets, 6 of which survived until the final endpoint of the study. There were several complications related to magnet placement and then some pneumothoraces related to secondary operations. We studied the piglets for 8 weeks. We did not have any leaks. The magnets had passed in stool by 16 days. And then on endoscopy at 8 weeks, we found that the anastomosis remained patent and easily accommodated a 6.5 millimeter scope, which was really also exciting. And again, the histopathology really also supported prevention of stricture with a mature anastomosis and complete neoepithelialization. Dr. Munster, you want to take it from here?
Absolutely, yes. Just a little correction from the last study. There were actually no complications from magnet placement, but the 4 piglets that died in the second operation due to massive adhesions between the chest wall and the lung. And that was because we initially did a second thoracotomy through the same side, which is in piglets almost impossible. It creates so much air leak. So we didn't really see any complications from the magnets per se, which was very exciting. And so we'll go on to the next slide. So after completing our first study, we felt that we were ready to take this clinically. And I had a patient that was a type A esophageal atresia, which means there's no fistula to the airways. And this was a very small patient, just 1,800 grams when she was born, a premature baby. And the reason we thought this was a good case was because of being so small, we would have had to wait a long time to get her together. And so what we did is we gave her a feeding G-tube, and we then in a second operation, thoracoscopically brought the ends together. So we basically sewed the ends of the esophagus of the upper and lower pouch together without creating an anastomosis or a connection between both. That maneuver sort of allows the esophagus to grow and to actually decrease the tension that is between those two parts of it. Then afterwards, we placed the magnets. They were placed endoscopically. And 7 days later, we had a well-formed anastomosis. She's been dilated 4 times to date, but she's doing extremely well, normal development, feeding completely by herself. And we closed the gastrostomy, obviously, and she's doing really well. She's actually one of the patients that you saw just now. If Lauren, if you go back, yeah, the one down there, and she's doing really well. So we got compassionate care ethics board approval for that case. Then we had a second case, also preemie with trisomy 21, who just by chance, they followed the alphabet. So our first patient had a type A, second patient had a type B, and the third patient had a type C, esophageal atresia. So the second patient had trisomy 21, also was very tenuous, and basically had the type B, meaning that there was a connection between the top part of the esophagus and the airways. And so we closed that, gave him a gastrostomy, and then again, in a thoracoscopic operation, brought the 2 ends together, and later did the same procedure endoscopically, placing those magnets. It takes about half an hour to do, or not even half an hour. So it's very, very quick. Again, the device passed by itself through the stool, and he's doing really well. We closed the gastrostomy. He's eating all by PO, and I'm actually seeing him week after next. So I'm very excited about it. Compassionate care kind of ended, so we had a third patient come in who was operated by a thoracotomy outside. She was actually a full-term baby, but she had dextrocardia. So her heart, instead of being on the left side, was on the right side. And the previous surgeons that performed the case aborted it after ligating the connection to the airways, the fistula. And they said it was very, very difficult to operate on that side because of the heart being there. So we found that this would be a possibility also to help her by our method. And so it was kind of a challenge because after the second case, the ethics board said, from now on, any further cases should be done in a study. But we explained that this patient would benefit from the procedure, and that it would not it would take a long time to get the study approved. so that they finally gave their approval for the third case. And again, we approximated the pouches. This time having a pouch that was previously operated on before, and then placed the magnets. Now this time, what we saw was the lower esophagus, and this is often the case in type C, was kind of slender, so that we had difficulty getting the magnet in. And maybe Lauren, if you go to the next, this is actually, yeah, this is her. So we brought the magnet in from the lower pouch, and it was very, there was only a tiny lumen. So we didn't quite get them together. If you look at the left side, they're not perfectly sort of parallel. And that led to the fact that a day later, the magnets had come apart. So we had to go back in again. And then on the right, you can see that we repositioned them in perfect alignment. And that actually led to formation of an anastomosis. However, this was an interesting case because of the small lumen of the lower esophagus. The magnets did not pass distally. And you can see, so this is what usually, go one further, yeah. So they were, even after 2 weeks, one further, you can see that the magnets were still in situ where her anastomosis was, and we had to take them out endoscopically through the mouth. And this is an image of the newly formed anastomosis with the magnets in place on the upper side. So we're going through the lower pouch and through the stomach. And on the right, you can see how nice this anastomosis has formed. I mean, there's a very nice area of mucosa covering it. So that's, I think, like Lauren said, the key to the new magnets. So if you go back one, you can see this is what should be happening. So the magnets are mated. Then after about 7 to 12 days, you suddenly see the magnets tip, like they change their alignment. That means that they've already disconnected from one side. And then on 2 days later, you see them in the stomach and then in the rectum. So all three cases, and these are consecutive cases, have gone well. They're all feeding. And I think this proves that the next appropriate step would be indeed to do a prospective study, clinical study. And I do think that this shows that we have the ground laid for a real study.
Awesome. Thanks, Dr. Munster. In addition to the compassionate use cases that Dr. Munster was able to do in Germany, we've had a really incredible opportunity to work with some stellar teams at Vanderbilt as well as at Stanford in the recent months to do a couple of compassionate use cases. I think that the patients for both of these cases are a little bit different than Dr. Munster's patients, just because both of these kids were a little bit older and a little bit more medically and surgically complex. And I think that these cases really speak to this other class of patients that could really benefit from using the magnets. So I just want to say a thank you to everybody at Vanderbilt, Dr. Zamora, Novotny, Lavorne, and Upperman, as well as everybody at Stanford, Drs. Fuchs, Bronzoni, and Dunn for working with this. We're really, really thrilled about these results. So the first case at Vanderbilt, we completed in January of 2021. It was a 13-month-old male who was quite surgically and medically complex, who had a long gap atresia, severe bronchopulmonary disease, as well as had a complicated course related to a perforation of the lower pouch, as well as a missed proximal TEF, and did have a history of bilateral thoracic operations, I believe 2 on the right and 2 on the left. So really for a traditional esophageal repair, he was high risk for both the anesthesia as well as a hands-on anastomosis related to tension. So we placed the mini-mag endoscopically. He had previously undergone a thoracoscopic approximation of the pouches during, I believe, his previous aortopexy for his severe tracheomalacia. The endoscopic placement of the device took only 38 minutes. There were no leaks or no device complications, and the device ultimately ended up being endoscopically removed through the G-tube on postoperative day 18. In terms of his more long-term outcomes, he did have a course that was complicated by a bronchoesophageal fistula that had formed in the area of a diverticulum that we think is probably related to his prior PEXI. It was quite proximal to where the anastomosis with the magnets were, as well as a stricturing of his anastomosis. So on postoperative day 29, he did undergo another endoscopy. On postoperative day 33, a self-expanding stent was placed, which helped address both the stricture as well as covered the diverticulum. And then actually, I just heard from Dr. Zamora today that on Monday, he underwent a combined case for an endoscopic closure of the diverticulum that went exceedingly well. They're very excited about it. So that's really, really thrilling news. And then these are just some representative x-rays. You can see on the top far right, the magnets getting placed endoscopically. The image just below that, the fluoroscopy image just below that was during the removal of the magnets, which shows a nice patent anastomosis there. And then the bottom two images are after his stent placement. In February, shortly after, we were able to do a case with the Stanford team, which was a 7-month-old male who also was quite surgically and medically complex, also had a long epatresia as well as underlying lung disease requiring continuous positive pressure, as well as having prolonged vent requirements. He also had a complication initially with a perforation of the lower pouch, so had multiple operations on the right side as well. And really, he was high risk because the gap was quite significant even at the time of his operation. So we did attempt an endoscopic placement of the mini mag first to try to avoid a secondary operation. However, we weren't able to bring the pouches together. And so ultimately they did end up performing a thoracotomy on the right side. And what they ended up finding was a significant area of fibrosis between the pouches that were preventing them from coming together. But during the thoracotomy, what they also found was that the upper pouch was quite socked in due to significant adhesive disease. And so ultimately they weren't going to be able to perform a hand-sewn anastomosis safely. And the only other surgical option for this kid would have been a cervical esophagostomy. So ultimately they went back and ended up placing the magnets again endoscopically with an open thoracotomy assistance essentially. And we're able to bring the magnets together, which was awesome because we felt really strongly that it really benefited the kid to be able to avoid a spit fistula. Now postoperative course, there was a possible subclinical leak. Looking back, the initial completion esophagram may have had some irregularity around the anastomosis. Ultimately, the magnets did end up getting removed on postoperative day 21. And in terms of outcomes, he did have a stricture that was going to require dilation. And on postoperative day 31, he was dilated to 6 to 7 millimeters. And unfortunately, that was complicated by a small to moderate size contained perforation that is now being managed conservatively, which we do think may have been related to that small defect in the anastomosis originally. And, in addition to how exciting, the compassionate use cases have been and how much progress we've made with the product, one of the biggest feedbacks or one of the biggest learning points I think that we've had is, placement can be a little bit clumsy with an endoscope. And so really what we've targeted our efforts towards now is developing a delivery device that would enable really easy kind of on-FOSC central delivery of the magnets, both through the upper and lower pouch. And so what this is showing here is it's a device controlled by the surgeon that actually uses an internal magnetic mechanism to facilitate precisely controlled delivery, release, and then also facilitate safe retrieval if the magnets are mated in a position that's not necessarily to the surgeon's liking. So we're very excited about this progress, and I will go ahead and open things up to questions from the audience. Yeah, any thoughts from the other panelists before we move forward?
Yeah, Rusty.
Hey, Mike.
Hey, Rusty. What do you think?
I think this is awesome. I think you've made a tremendous amount of progress. I will tell you, unpublished data, that the current status of the magnets that are available, I think they've done between 7 and 10 cases, and already 4 of them have been referred to the EAT Center for major complications, perforations, and severe, what essentially is an anastomotic disruption with a 2 or 3 centimeter long stricture.
Yeah.
And I think the problem is the design of their magnets. So I think there's a lot of work that we can do to make it better. One of them is just your design of the magnets is for the mating surface is very, very good. So I think there's a huge amount of potential. I'm very, very excited about moving forward with something that's going to be better than what's currently available.
Well, we're excited to work with your great team at Boston Children's and all your, I mean, you have tons of patients and tons of experience and tons of expertise.
Yeah.
I'm really curious about, and we'll do this together. We'll do the trial together with you and a few other great places. That'll get done. The next question beyond that, Rusty, is stricture. What do you think?
Well, I don't think the anastomosis is the holy grail that you're going after. I think everybody wants to do that. And I think I will say that's where people are falling short of using the current magnets that are available. The device is used inappropriately, which every one of the cases we've referred to us has been inappropriately utilized. If somebody's already had surgery, they've already got some complication, and now they're trying to salvage it with the magnets, when they should just refer it to a center of expertise who can fix the problem.
Yeah.
Strictures, we've had hundreds of esophageal atresia we've repaired. We've had thousands of strictures. Literally, I think we're at like 1,500 or something. It's some enormous number of strictures. It's a much bigger problem. And I think the magnets are probably much better applied to solving the stricture problem, because so often the balloons we use to dilate the strictures and the stents we use to treat the strictures cause further problems. And now you spiraled into a trouble that you can't get out of, and you have to do another operation to resect that stricture, because the balloons are longer than the stricture. They make the stricture from 3 or 5 or 7 millimeters long to 2 centimeters, 2.5 centimeters long, because they damage the tissue with each dilation. And I think if you can use some sort of a compressive device, one idea would be the magnets, you can actually shorten the stricture while you're making it more wide open by compressing and necrosing that tissue. I think it's a much better application.
Perfect. Love it. Well, we're working like crazy on it. I don't know whether you tuned into the morning session with the competition. One of them was our team presented the Magnamosis for stricture. We're right at the beginning of that deal. We haven't actually done one on a human yet, but I agree with you. I think it's a great field. It's a great unsolved problem.
It is really needs a better solution than what we have currently. Yeah. There's no question. And not only that, every bowel anastomosis, every anastomosis, you always get a circumferential scar that contracts, and there's got to be a better way to do it.
Yeah, couldn't agree more. So, Lauren, what do you want to do now? Well, first of all, I want to say thank you to
please.
Our German colleagues, because I was privileged enough to be in the operating room for the second patient, and it truly took, I think, a half an hour. I mean, it was the slickest thing I've ever seen. Of course, you got a slick surgeon too.
Well, we have one comment from Dr. Zamora just letting us know about the first compassionate use case that was done at Vanderbilt, saying he continues to do well. Thank you all for your help with this incredible, innovative, transcontinental collaborative case. Hopefully he'll be going home for the first time next week, just short of 1 year since he arrived in our care, which is so exciting. And then we have a question for Dr. Jennings from Doug Mignotti. I wonder what his thoughts are regarding the inability to perform a simultaneous tracheopexy with the TEF repair if the magnet approach is taken.
Good question.
I think it's great. I think the posterior tracheopexy and the diverticular resection and the TEF resections are all quite advanced techniques, and they're not standard of care yet, although they should be. They will be eventually. And only 80% of kids with esophageal atresia have tracheomalacia. And some of those can be, probably 20 or 30% can be treated medically. So I don't know that I think it's worth pushing ahead on MIS techniques, whether it's magnetic or thoracoscopic or whatever, keep improving them. You can always go back and do a posterior tracheopexy. We do that 3 times a week. Some kid has an esophageal issue and we go fix the airway, because the airways are such a big problem. And just to whet your appetite, I think there might be magnetic solutions for posterior tracheopexy. And we can talk about that offline, but I think we're just now entering an era where we can start talking about some really, really cool stuff.
Wow.
But yeah.
Okay,
Dr.
we got to
Munster.
keep talking about that. That's why it's so much fun to work with guys like Rusty and Oliver, because they're just constantly thinking of new problems to solve.
Dr.
There are
Munster,
more
do you
problems
have
out there
any
that we can
thoughts?
possibly solve.
I'm sorry. Dr. Munster, any thoughts?
No, I agree. Well, I do think that you have to know what it's good for and what it's not good for. So the magnets are not there to approximate pouches. I think that's very important. They make anastomoses and they don't approximate. And I think part of the key issues is that we got the ends together and gave them a lot of time to decrease tension before we put in the magnets, you know. So that's important. I do think that there's a lot more to be solved, you know, and I think that we can expand. I mean, you would like to really, you know, not necessarily do these or use these magnets like Rusty says in the kids that have had, you know, dozens of operations. You actually, I think where the real application is for the standard type C esophageal atresia. The question is just how to get them, you know, get the magnets there and how to close the fistula all in a very minimally invasive way. But I like I do like your term of democratization of this. I mean, the problem with, I do a lot of thoracoscopic esophageal atresia repairs, but it's so difficult and it's hard to train people. And it's not something that you can, you know, with a good conscience have recommend everybody doing, you know. And that's where I think we need to get it down where the, you know, you don't need to have super high endoscopic skills to do these.
I think one of the concepts of having done literally hundreds and hundreds and hundreds of esophageal anastomoses, I can tell the esophagus doesn't tolerate too much tension. And the problem with the magnet is it's a R to the fourth force. And the closer you get, the more the force goes up by a tremendous amount. And that last centimeter or so can destroy the esophagus, which is why we're having these complications with the Flourish device, right? They get close and all of a sudden they stick together. The muscularis falls apart and you're left with a mucosal tube, or worse. We have one kid who has both ends wide open. You leave with something bad. And so that force has to be modulated in some fashion if you want to induce the growth component. The anastomosis component with compression anastomosis, I think Mike has proven, and everybody else has proven over time, it's a great technique. The growth component maybe is not quite perfect yet.
Totally agree, Rusty, with both you and Oliver. I've always thought that the business of growing the esophagus should have nothing to do with magnets, because the force is wrong. As you said, it gets, and the closer it gets, the harder it pulls until it ruins the esophagus. You know, use some other techniques like the ones you use to grow the esophagus, and then when they get close enough, you can do this last part endoscopically. Yeah,
no, we use several techniques to grow the esophagus, and I'm not by any means saying we're perfect. Believe me, we're not. There's always some trauma or difficulty, but we're on the right path, and that's tension-induced growth.
Yeah.
And if we could just modulate the magnetic force, you know, the force was really modulated pretty well in the late 70s by Hardy Hendren with his electromagnet magnets and pulsatile force. He figured it out, and we're still trying to figure out his techniques. There was a guy in Germany who was doing it for a while. I forget his name. He did several cases quite successfully.
Rabine. The same. So so he did it in the 50s. So you know, when you talk about magnets, everybody that I talk to, the old pediatric surgeons in Germany, so we've done this like, you know, 50 years ago. So they used them. But again, I think Rabine used them not for anastomosis, but for getting them together.
Yeah, I don't know. I think he was doing it more recent. I know the guy retired. I remember seeing a lecture 5 or 10 years ago thinking, boy, this guy's really got it figured out.
Well,
I forget,
they probably had it from him, you know, like a lot of ideas get recycled. And
Maybe that's it. But I think we have proven, as have others, I'm sure you've done it, that tension does induce growth. Whether we do
Yeah, for
suction
sure.
or springs or magnets, we've just got to be able to modulate it so that we can not overstress the tissues and decrease the perfusion and lymphatic drainage at the same time inducing growth.
Yeah.
So we've got another topic for discussion that's actually something that the lab has talked about quite a bit. So I'm kind of eager to see what everybody says. Dr. Zamora is asking, so he says, to your point, Oliver, moving forward, how do we envision placing the magnets in at the first operation in a standard type C thoracoscopic repair without a G tube? Or will we be subjecting all these patients to a G tube with a magnetic approach?
so we've talked about that internally, all of us, and I think there's several components to that. I do think, so it's going to be hard to get a magnet through a fistula. That would be the possibility to induce or bring everything in from above. But I do think that the key to these magnets is that you have two of the same kind that attract each other, and having like a little ball or something that you put through the fistula bronchoscopically might work. I think that the challenge then is getting endoluminally closing the fistula. I do believe that the first step would be to subject all of the kids to a gastrostomy. I don't think that's so much of a big problem because, it's a little scar in the abdomen, but it might be, it basically avoids a large scar or several scars in the chest. I would say you would have to get some kind of a clip or something across the fistula. I think you should use something that's not magnetic, like a plastic clip or so.
Yeah.
And then because type C usually are not so far apart and they're not long gap, I think you should be able to do this endoscopically from below and above. But you do need to, for now, I think the solution would be to thoracoscopically place a clip or two clips, dissect this fistula, and then place the magnets from above and below through endoscope.
Perfect, Oliver. I totally agree. I'm interested in what Rusty has to say.
I'm sort of opposed to the use of non-absorbable equipment like clips because they end up eroding, causing leaks and fistulas, or they end up in the lung, or they end up coughing them out. So having done many of those, we get it. So we don't use anything non-absorbable. But I would be all for an absorbable device that would close the fistula and try to remove the diverticulum as much as possible. I think that'd be terrific. There was a long time ago, God, I could never give you the reference because it's old, but there was a Japanese surgeon who designed a technique of endoscopically, through endoluminally, doing an esophageal anastomosis. It might be worthwhile to have one of the research fellows go back and try to look that up because it is sort of involved inverting one end into the other, doing the anastomosis and then letting it back out. That way you take care of the fistula and end up with an esophageal anastomosis. So I don't know if he ever pushed that any farther. It looked exceedingly complicated.
Yeah, wow.
But complicated doesn't mean it can't be done. It can't be done with some sort of device.
But we need to think together about our trial, because we're pretty much ready with the experience we have now to do a proper trial at a few good centers. Yeah. And I think what we have to discuss is what exactly the technique will be. I favor what Oliver talked about, a thoracoscopic ligation of the fistula, and then a gastrostomy, and then you got it made. You got it from both ends.
I would say,
Rusty, what do you think? I think a lot of American pediatric surgeons don't like the idea of a gastrostomy since we got away from it 20 years ago. What do you think?
I think the lessons we've learned from the Flourish device, they're really struggling because they're having so many complications. And I just told you 4 out of 7 end up on our doorstep with complications.
Yeah.
I think they push too hard. I think we should design this trial for success. Pick the easy cases, pick it so you're going to win. Once you win, then you can move forward taking on progressively, very thoughtfully, more complicated cases. So maybe going for the, for the gross type A cases with no fistulas, or if you do a gross type B with a proximal fistula, do a next dissection, divide the fistula, then do a magnetic anastomosis. I would go for the G-tube because it's the easiest thing to get your anastomosis. Great. Get 5 or 10 cases under your belt where you win, it's a success. Then take it on the hard cases, because otherwise you're gonna end up with big troubles.
Yeah, well, that's why I think we want to round up the people and the centers that we trust to make those judgments. We don't want it to be used in cases that aren't going to work.
Right. Exactly, because that's really hurting florists right now and trying to write up their cases.
Yeah.
I remember about 10 years ago, I was using clips. We had clips that dissolved, self-dissolving clips. And I wonder, but they were relatively big, if I remember correctly. We used them for appies. But I think, with such a distinguished audience who are all eager to develop devices, I think that would be a device that should be developed, a clip that resorbs relatively quickly, in a month or two.
You only need a month or two, yeah.
Yeah.
And I agree with you, Rusty, that, I would never place a metal clip or something on the esophagus. And I've gotten away from, I used to put the plastic clips on, but, I've had 1 or 2 fistulas from that, in the past, and I don't use them anymore. And I want something that goes away. Yeah, absolutely.
So we have about 3 minutes left before the end of the session. Does everybody want to make just a final closing comment? Or Dr. Harrison, you want to say something?
I just want to say thank you. So there's nothing like having real expertise in the room, and we've got it. And that's why I think we'll be, I'm not a bit worried about a trial of this device for esophageal atresia, because it's going to work. If we do it carefully, like Rusty says. And hey, Oliver, one of the issues for us is if we try to get funding. In funding to do it for you to do it in Germany, because we want you on board. You're our leading guy. But if we have U.S. funding, we may not be able to do that. Any solutions to that problem?
Well, I mean, as long as you send me the magnets, I'm fine. I have the patience.
Okay.
But I think that's an issue, and I think one thing is writing up the protocol for the trial, and that's going to be a lot of work.
Yes.
And then it would be really nice to get a CE marking on our magnets, honestly. And I'm excited. Once we have the FDA thing going, I think that would be the next step, because then I can use them much more liberally.
Yeah.
It's really hard to get this through an ethics board approval if they're not even, if you don't have any, if it's basically off the street,
Yeah. So our team is putting together that protocol, and I don't know if we've sent it to you and Rusty yet, have we?
No. It's still kind of in the
what? For the study.
Mm-hmm. We've been thinking about
it. We have to.
Let's do that, and we'll get it. Submitted here and there, and then we'll recruit patients. And I think at the same time, you're right. We need to, internationally try to get funding for these. Yeah.
Well, I want to say thank you to all the panelists. Thank you, Dr. Harrison, Dr. Jennings, Dr. Munster, for everything. And I will go ahead and pass it back to Dr. Lee and Usha.
Thank you. That was a great session. And Rusty, I'm sure you can concur. It seemed like one of the old meetings up in Parnassus, HSW 1600. Absolutely. So nice to see that dynamic. I think I'm going to turn it over to Mike to introduce Professor Grubbs.
Well, it is a great pleasure to introduce Bob Grubbs. you can see in the agenda, he has his credentials there. But the nice thing about really accomplished people is you don't have to say what all the credentials are. You say, well, he did get a Nobel Prize. What the hell? He must have done something good for that. But anyway, Bob Grubbs is our buddy from Caltech. I've been really delighted to work with him for the last 10 years in something that he and some other UCSF and Caltech people organized, which was a Caltech UCSF innovation meeting. We do it once a year. We've done it every year, and it's been incredibly productive. So the idea was to get UCSF surgical problems, unsolved problems, in front of the wonderful engineers and scientists from Caltech. That has produced a ton of collaborations and even some very successful startup companies. And I think Bob's been involved in all of those. So not only is he a Nobel laureate and professor chemistry and chemical engineering at Caltech, but he's also an avid fly fisher. That's probably the most important thing. And he's also the father of a very accomplished maternal fetal medicine pioneer who is practicing down in the Los Angeles area. Bob, is there anything else I can say, or we'll let you do your thing?
Okay, do my thing. Thank you. Here we go. So thanks, Mike. Yeah, it's been great fun for the last 10 years. And so I thought I'd tell you a little story about sort of what happens to chemists who get who sort of pick up a hobby along the way, and it turned out to be something that's great fun and something that's there. And so I'm a PhD. Used to pass out at the sight of blood, so I had a problem with that area. And I'll tell you sort of the story of how sort of I wandered from being a sort of standard organic chemist, teaching the course that that many pre-meds love, which is sophomore organic, and then ended up sort of working in the medical device area. And so, you know, most of my career and what most people, most chemists know me for are developing catalysts for doing organic chemistry. And I've worked mostly on this crazy reaction that shuffles carbon-carbon double bonds. And it looks simple. And we made some nice catalysts, and those catalysts turn out now to, so the first Hep C drug was made using our catalyst, and there's now some really exciting stuff in staple peptides from aileron. We can make big stuff. We can make wind turbines, and so we just made a 35-meter wind turbine. In Indonesia, they're turning seed oils into products. We can distract and confuse insects by making insect pheromones, oil and gas, et cetera, et cetera. So anyway, so that was sort of my life, and I was sort of cruising along and publishing my papers and having fun and, you know, doing all that stuff. And one day someone showed up that sort of changed things. But before we get there, I mean, a little bit about organic chemistry. So when I started, and I started doing organic chemistry in 1963, so that was a few years ago. And so at that stage, you know, it was early days of organic, modern organic chemistry. You know, we'd make stuff. We worked like hell to find out what the structure was. Oops. And then we would try to, you know, see how it reacted and try to learn something about it. And then we would go back and make new things and do structures and function. And so this was sort of the pathway that we followed. Now, you know, now we've done that enough. So now we know how to do it the opposite way. And so now we can define a function that we need. And then we know enough about structures to be able to propose a structure that's going to fit that function. And now in the last 50 years, there's just been a tremendous number of new synthetic tools that are made, which allow us to make stuff. And so everything was sort of primed. You know, in the mid 80s, Arnold Beckman showed up at Caltech, and he was interested in intraocular lenses. I worked with a group at Doheny at USC. I always sort of chosen for this because I was the only one at the time who could say polymer at Caltech. But that primed me for a really changing event in my life, which was Dan Swartz showed up in 1996. Can't believe it was that long ago. With a bunch of problems that were associated with the eye that he thought chemists might be able to help with. And, you know, out of all of those, there was one which I was working in holography at the time, and so we used the techniques that had been sort of developed in holography to solve a problem, and started a company called Calhoun Vision. You probably don't know, but the name came from Calhoun Street, which is where Dan lives in San Francisco. And a few years ago, the pros came in and they changed the name to RxSight. And so essentially, in this case, you know, you got the lens capsule and then a cataract. The lens sort of clouds up, and so then they go in with a sonicator and basically break up the lens and suck it out. And then they put in a intraocular lens, which is a lens made from various pieces of plastic. They do a lot of measurements ahead of time, so they hopefully put in the right power of lens. Problem is, you know, ahead of time, there's a cataract there, and then there's a lot of sort of damage done during the surgery, so things heal differently. And but it's a tremendously successful surgery. And what Dan pointed out is that, you know, there's millions of these done every year, and most people can get best corrected vision if you use glasses, but about 50% of the people have to wear glasses. So that was okay before, but now with LASIK and other things, people now really want to put away wearing glasses. And actually, I'm looking forward maybe to getting one of these lenses soon, so I don't have to wear glasses. And so Dan proposed a problem, and this sort of started everything. And the problem was, can we make an intraocular lens that is exactly the same as, you know, put in the same way, everything is the same. But instead of putting on glasses after everything is healed, can we change the power of the lens inside the eye? So this struck me as being a really interesting problem, and happened to come up with a way of thinking about doing it. That was, you know, 96, 97, and I'll show you now we're finally getting to be successful. So this has taken a long time. And so then at Caltech, we put together a team. Dan really helped with the funding, and that's really one of the keys to this business, is how you sort of do proof of concept. So we did proof of concept with 2 postdocs at Caltech, and then we formed a company called Calhoun Vision, which was located in Pasadena, just down the street. And the 2 postdocs became the first 2 employees of the company and really got things started. So what was the idea? The idea is you make a lens. It's a cross-link polymer. We did a silicone, and then in the silicone we embed what we call a macromer. So it's a short polymer which doesn't polymerize during the first polymerization procedure. And then we put in a lot of photo initiators and stuff, so that if you shine light in the middle of the lens, for example, these macromers polymerize and turn into big polymers. And so what that does then is that sets up a chemical gradient. So the small polymers move into that region and cause that region to swell and the other area to shrink. So it's a very simple idea. It's basically what I wrote down in 96, and it's just taken us a long time to get there. And so and then after you're happy with everything, you just shine light on the whole deal and lock it in. And so this actually turns out to work. This is Dr. Chayet, who the surgeon who did all of our outside the U.S. studies and was phenomenal and really was a huge help. And so this is the device that delivers the pattern of light. and you develop the pattern of light by using a chip from a projector. So it's very easy to do. And so here's sort of the results from, this is probably 10 years ago, but didn't show later stuff. But anyway, this is still sort of holding up, is that basically 100% of the people have 20/25 vision or better. And we even have about 25% of the people who have 20/16. So it works, and they really improved it so one can have far near vision, et cetera, et cetera, et cetera. So, and so this was a problem then where a clinician proposed a problem. It was a totally outrageous problem, actually, just thinking back. I'm still amazed we've been able to solve it. And, you know, we followed through and it worked. The FDA, for example, standards for how much light you can put in the eye were all wrong. So we designed everything super safe and turned out it wasn't safe. So I had to go back and redo everything. So it's been a long haul. And so now the company's called RxSight. It's, you know, the final results were good. We finally got FDA approval and for the first farm in 17, next one in 19, and sort of the third one is pending. Hopefully we get it pretty soon. And these are all improvements on the lens, and the product's now being sold commercially, and large number of clinics around the US are now in the process of selling and using this lens. And so this, for Dan and I, turned out to be a good model. And so as Mike said, we started a bunch of discussions. And so, you know, probably 8 or 9 years ago, Dan and I realized we were having way too much fun because Dan would come to Pasadena and we were supposed to be running a company, but neither one of us liked to do that. So he started teaching me other areas and coming up with other problems. And we started working on lots of other projects. And so we decided we'd get other people involved. And so we initiated a series of innovation seminars. And the basic idea is a lesson I learned, and I'm sure many people have learned it, but many haven't. And that is, if you're going to work on clinical problems, you have to have a clinician involved from day one. I have many young colleagues who tell me they're going to solve a problem, and I say, "Who are you working with?" And they say, "Oh, you know, this is too good to be, you know, to have a problem." You know, on and on and on. And I say, "Look, you're wasting your time because if you don't have a clinical person working for you from day one, you'll solve the wrong problem almost every time because the requirements for success are very different." So then the question was, is how can we increase the interaction? And so we started this series of seminars, and Mike, we actually have them twice a year. And so, you know, and so basically the first one, and the other lesson we learned from this is that that Dan and I decided we were going to do this. I sort of twisted the arms of 10 or 12 engineers and chemists from Caltech. He did the same with a bunch of clinicians at UCSF. We had no money. Everybody, the Caltech people flew themselves up to San Francisco. We had a meeting. It was so successful that people keep clamoring for us to keep doing it. Since then, we raised a little money to do stuff. But the key is that we started at basically grassroots, no big program. I've tried to do this with other universities, the deans and the provosts, and everybody gets involved, and none of those have worked out at all. So we've been doing this for a long time, and it was so successful that Dan has now been hired part-time as a clinician in residence at Caltech. And so he's now spending his time having fun, interacting with the whole campus and trying to connect the right people from engineering and sciences with the right clinicians to make stuff happen. And now Caltech has a medical engineering program, which is a new program the last few years, and it's partially based on sort of this kind of interaction and this kind of work. So what sort of has come out of this? And, you know, I'll pick a few to show you in a moment, a couple of cases, but, you know, the first one was this IOL. And then sooner after, Dan introduced me to Mike, and we started working on trying to make glues to glue up the uterus in and amniocentesis and related things. We're still working on that one. That's a really hard problem. But we learned a lot about making glues, and we had a good time. There's a lot of other people. I worked with Steve Hetz on making a chemo filter. This one came out of the group. And I'll talk about this one in a moment. With Marshall Stoller, who's a urologist at UCSF. Dan and Grieve are working with corneal blindness. This is something I'm really excited about. So this is sort of the situation. Is Dan started talking to me about AMD about 15 years ago. We probably come up with 10 approaches. None of them we liked. We recently came up with a totally outrageous one, which is now we're raising money for human trials. And so we'll see where that one goes. This is one I'll talk a little bit about later, but collapsible balloon. And so Mike and I have been talking about this one for a long, long time. And again, we've tried a lot of different ways, but I think now we maybe have a way of doing it. Portable dialysis with Roy, and other people are involved. So this is just a few of the examples. And so out of these sort of one-day meetings, a lot of good contacts get made. Mostly now they involve the clinician presenting problems and the scientists and engineers trying to think of solutions and how to sort of approach them. And so it's been a really exciting. These days are tremendous. So a couple of examples. The Marshall's been involved in, I think, every way of treating urinary stones. And if you don't know him, he's probably the most energetic person I know. Mike, don't you and Marshall walk to work every day together, I think? So he wanted to develop a way of treating urinary stones that didn't involve an operating room. And so he had an idea of being able to somehow or another to focus the ultrasound on the stone without having to do all kinds of aiming and getting a thing. And so basically the idea is to be able to tag the stones so that the ultrasound interacts with the tag and cavitates and breaks the stone. So that was sort of the general idea. And so there were a lot of ways of thinking about doing it. They were thinking about doing MEMS, but it turns out bubbles are what works. And so the basic idea would be able to do a treatment that you could do in a physician's office. So you show up with a stone, and instead of having to wait a week and take a lot of opioids and various other things, you go in the back room and it gets solved. And so I'll show you in a minute, a little bit of the stuff we did. And so once we had sort of a proof of concept, we started a company called Applaud with Stoller and Tom Kinney, who's a mechanical engineer at Stanford. So the basic idea is to inject gas bubbles through a catheter and have some way for those bubbles to preferentially bind to the stone. And then you could just use a general broad ultrasound source, so it didn't have to be focused. And so the only place that energy would be absorbed would be on the stone, and the rest of the kidneys and everything else would be okay. And so then you blow up the bubbles, they cavitate, they chip off a bit of the stone, and then you inject some more, and you keep doing it until the stone goes away. And so that's been the technique. And so the chemistry then is, one is choosing the bubbles. And so we identified bubbles as the right way to go. And then the next thing is doing the chemistry to make it work. And so the basic idea is to make bubbles. And so we use a phospholipid. We'll make the vesicles. There's a freon in the middle, of fluorinated hydrocarbon. We basically rip these off from a thing called affinity beads, which are used as contrast agents in ultrasound. And so then the idea is to have some kind of linker and then have a binding group on the end to bind to the stone. And so basically the game is learn how to do phospholipid chemistry, which is a bit of a pain, and then choose a linker, and a lot of those chosen. But the key is the targeting group. And so it's been shown that these bisphosphonates will bind to hydroxyapatite, which is what 80% of the stones are made from, and sort of works. And so we basically made these things. We did work in the lab at Caltech, show that they would bind the stones. We then blew up a few of them and showed they would start to chip the stone. And then we went off and formed a company and got people who really knew what they were doing, and it's really moving along pretty well. So it was founded in 2015 in the QB3, not far from you guys. Learned how to make the phospholipid bubbles. And so we did trials in Australia and about 40 cases to show that it worked. My favorite case there was the triathlete who came in with a stone. He obviously hadn't been drinking enough water, and pain of 9 out of 10. They did the treatment. He left, and then we couldn't find him again because he was feeling too good. So and so recently just closed B round, and we're going to start a U.S. trial pretty soon on this. So this is a case again where it just happened that Marshall talked about it at one of these meetings. He had the basic concept, but not the basic chemistry and how to do it. We identified the bubbles as the right way to go, and then developed the chemistry for putting on the tags. And then we went back in and formed a company and let things go from there. Another thing Dan and I have been working on for probably 15 years, and it's killing us, but we'll get there, is a way of treating a disease called degenerative myopia, which is a case where the eye thins and swells, and it's a huge problem. It's a major cause of blindness in Asia, and and there's really not a treatment for it now. And so again, chemistry-wise, so basically the idea would be to put something behind the eye that would be an activator, and then be able to shine light or something through the cornea or other parts of the eye, so you could activate regions on the sclera in the backside to cross-link it and make it stronger. And so we've been working hard on all the chemistry, how you deliver photochemistry, how you activate stuff. These are bunny eyes. So the one on the right's been treated, the one on the left hasn't, and it swells, and so these have a pressure. I'll do it one more time. So you can see the one on the left is swelling and the one on the right is not. And if you overlay them, it turns out that the treated one didn't swell and the other one did. And so sort of working, the question is now is how to get the right delivery and not do serious damage to the whole eye. And so we're getting close on this one. This one we're about ready to we're going to do the big proof of concept and either move forward or end it. What I'm really excited about now is something I've been working on over COVID time and getting stuff done. And so this is, again, going back to the early days. So we want to make a material that you can adjust after it's been implanted and healed. So what we need are materials so we can control the shape change. So we'll do this either ultrasound or inductive heating, a lot of other things. And so you can imagine having sutures where you could do your surgery, put the sutures in, and then go back and either release or do whatever. Remote opening valves. This we're doing for the Harrison project. This is for fetal balloons, so one can open them externally by using ultrasounds. We can deliver things, make adjustable implants, et cetera, et cetera. So this is sort of now getting to the proof of concept stage. We put together the team, we're making stuff, raising money, and so hopefully soon we'll get this material made. And then once we understand the material, there's many places it can go. But again, it's a chemist thing. So we know how to make stuff, we know how to put it all together. We have a good idea what the function is going to be once we put it together, and we got the synthetic tools to be able to make this stuff. And then we got some good engineers around who will help me do the ultrasound and that part of it, and then clinicians who will really help us develop it for special applications. Okay. So anyway, the common features of all these things is that, you know, the clinician identifies a real problem. We don't go to the clinician with a problem and say, you know, here, we want to solve this. We go to the clinician and say, well, what's the problem we need to solve? And I love to solve problems. I think that's part of Mike. Also, Mike loves problems. And so the more we can find and the more things we can do, the better it's going to be. The clinician helps define what the problem is. And the key is finding clinicians who can do that, who can define a problem in the right way so we can understand and really start to approach it. And then our job is to be able to you know, then do the science, do the chemistry, get the material to the right place. Well, one of the big problems in all this has always been finding postdocs and how to support them at the proof of concept stage. And we're continuously working on how to raise money for that. And then if you get the proof of concept, then, you know, you follow up with patents and then you go find a company to license them to, or you start a new company. It's always been hard to license to existing companies. And so we're on the startup thing. I think I just did my 10th one or something. So anyway, so basic science and engineers can make contributions to medical problems when they're properly identified. And I think that's really the key. And, you know, the exciting thing today about listening to the talk and listening to the last talk is that, you know, there's all kinds of interesting problems there. I think, again, if it's that discussion were held with scientists and engineers so we could ask questions, I think there's another set of things we could do. And for example, Mike, next time we talk, I've been thinking about injectable magnets.
Great.
So remind me to talk about that.
Okay.
Okay. Because I was just thought of that, and I got to think about it and make sure there's nothing crazy. Anyway, so thanks. So thanks for inviting me. Congratulations, Mike, for everything you've done, and I hope we can continue to work together for the next 25 years.
Thank you, Bob. That was amazing.
Thanks, Bob. Shivo here, and it was a great discussion of how a non-clinician works with clinicians, and you've certainly shown us examples that are very inspiring. I guess one question I would bring and open it up for anybody else that has a question is, what are some of the frustrations you've had? You've talked about all the good stuff.
Oh, I mean, we've had a number of things that haven't worked. And also the main thing is funding. Just trying to be able to put together enough funds to hire a few postdocs to keep things going. So that's driving me crazy in my old age, is how I'm going to keep things going for the next few years of having a few postdocs around who can work on projects and work on a lot of different projects and do the proof of concept, and also finding the right ones, because you got to find the right postdocs. A lot of times postdocs really want to do academic stuff, and that's fine. But finding people who are really good, who can really think, and are really creative, who can work on these kinds of projects, that's also quite difficult.
Yeah, I think you hit on an important point, because the traditional mechanism for funding in the academic, especially the academic biomedical sciences, NIH,
yep,
there's a relentless push towards just getting papers published, forget
it
has to have patient impact. And I think that does detract from the enthusiasm of some of the academic engineering or non-clinicians to participate, because they don't see a way to get their career moving. And as you and many of us know, when you go up for promotion, that's the challenge, and that we have to address.
Yeah, you know, and the other problem with NIH, it takes forever. And so you have an idea and you want to go try it. You don't want to wait for 2 years while it goes through study section and all kinds of other things. And so having an ability to sort of, here's a crazy idea, let's go try it while you're still excited about it. And I've reached the age where if I don't try it pretty soon, I forget about it. So.
All right. Well, thank you. And we're glad to have you. And thanks for joining us in this journey with Mike here. So we're going to now move on, and we're going to talk about a different topic, also very close to Dr. Harrison's heart, which is fetal and neonatal ECMO. And it's my pleasure to introduce the panelists today and the speakers. Robert Bartlett, Bob Bartlett from University of Michigan and his colleague George Micheliska. Dr. Alan Flake from Philadelphia Children's Hospital. And then one of the fellows in my lab, David Blofeld, who's going to talk about some of the work we do. We're really pleased to have these pioneers with Dr. Harrison present to us, and we'll see where, we'll have a good panel discussion towards the end. So I'm going to get started by having Dr. Bartlett go first and his colleague, Dr. Micheliska, and then we'll continue. So, Bob?
So hello, thank you so much for the invitation. Hi, Mike, good to see you again, and a lot of other old friends. George and I are going to talk about ECMO, and I'm going to spend just a minute to remind you a little bit about the history. In the 60s, Phil Drinker and I built a membrane oxygenator, and with that demonstrated that we could maintain animals on extracorporeal circulation for days at a time. I moved to UC Irvine with Al Gazaniga, and we put the first pediatric cardiac case on what we now call ECMO in 1972 with success. And in 1975, we put the first newborn patient on with success. And that case turned out to be very important because that was the growth of ECMO for the next 10 or 20 years. The technology that was used was primarily veno-arterial access, draining from the right atrium, reinfusing into the carotid. And over the next 20 or 30 years, the number of centers is shown here, the number of patients is shown here. The whole project moved to the University of Michigan in 1980. So the number of neonatal respiratory cases, which was most of the cases in the early days, is shown here year by year. What happened in this year was inhaled nitric oxide, which solved a lot of these persistent fetal circulation problems. And right now there are about 800 cases a year that are entered into the ELSO registry that are neonatal respiratory cases. This is the survival per diagnosis over 30 years of time, but only look at the last couple of years. So meconium aspiration and RDS have a very high survival. These are the indications, by the way, are patients who are failing on mechanical ventilation despite all other treatment. So 80, 90% recovery is good. The lowest result is in diaphragmatic hernia, although the current survivals are at about 60%. That remains a challenge for us, and it's all related to lung hypoplasia. And some of those children, the lungs simply won't grow over 6 months or a year. In pediatric cardiac cases, the use is shown here. Like other ECMO, it really picks up in 2010 because of new devices that are available. And this is the survival rates for pediatric cardiac cases, only a few cases in the early years. But now, myocarditis and cardiomyopathy have about an 80% survival. ECPR, resuscitation and arrest, has about a 50% survival, and most of the cases are congenital heart disease, usually post-op, which have about a 60% survival. So to put that in perspective, this is the neonatal cases in 1990. Almost all the cases are neonates. As I showed you, the number of cases stays the same, but as a percentage of cases managed with ECMO recorded in the registry, nowadays it's less than 10%, and the rest is older children and adults, and the major growth has been in adults. So there are many applications of ECMO. It's just a way to keep people alive who would otherwise die of cardiac or pulmonary failure. One of those cases is extreme prematurity, and that's what George is going to talk about. George, you're on.
Okay, can you hear me?
Yes.
Okay, terrific. Thank you, Mike, for inviting me. It's great to see so many familiar faces. And I think Dr. Harrison will appreciate my title, The Unsolved Clinical Problem. I will be speaking about anticoagulation in the artificial placenta. Hold on. My disclosures are that I think I'm the only person here today who has had the great fortune of being mentored by two great innovators, Dr. Michael Harrison, the father of fetal surgery in the early part of my career, and I have the good fortune to be mentored by and work with Dr. Bartlett, the father of ECMO. I'm having a little some AV difficulty here. Here we go. So I'm going to be focusing on this population, the LGANs. And the LGANs are defined as infants less than 28 weeks estimated gestational age, and their mortality and morbidity is particularly high. And we all know the outcomes are worse with decreasing estimated gestational age, with only 22% surviving without morbidity. And I would argue that LGANs are essentially fetuses with immature organs, and the complications of prematurity, intraventricular hemorrhage, NEC, BPD, ROP, and sepsis are iatrogenic. And the ideal growth environment is a recreation of fetal physiology with fetal circulation, low PO2, and no ventilation. The goal, therefore, is to recreate fetal physiology. And the main aspects are maintaining fetal circulation, a low oxygen environment, fluid-filled lungs with no mechanical ventilation, and either VV or AV ECLS platform. This is our AP circuit. We use a VV ECLS platform, and you can see the reinfusion cannula is via the umbilical vein. The drainage cannula is via the jugular vein, and the lambs are intubated and their lungs are fluid filled. This is a picture of an animal in an isolate. You can see the endotracheal tube is capped here, but more recently we've had it to a meniscus where the animal can continue with fetal breathing movements. And we've shown in this model that we have long-term survival with hemodynamic stability and fetal gas exchange. We've also done and examined virtually every organ system and demonstrated that the organs are protected and continue to develop. One of the milestones for clinical application, or the elephant in the room, is anticoagulation. So as you can see in this slide, all babies that are born very premature, 29 to 33 weeks, their rate of intracranial hemorrhage is 1 to 5%. And we know from a limited experience with preemie ECMO, looking at the ELSO database, that when these babies are systemically anticoagulated, hemorrhage rate is 21%. Now, when we at LGANs less than 28 weeks EGA, we know that rate is 18%, and we don't know this number, but we presume that this would be much higher than 21%. So to bring the artificial placenta to clinical translation, we need to solve the problem of anticoagulation. And our solution is a surface-based local anticoagulation, which anticoagulates the circuit in the cannula has no systemic effects. And this is work that Dr. Bartlett and Dr. Meyerhoff, a chemist, have been working on for over a decade. And it's a coating for the circuit that is made with DBHD and argatroban. And the DBHD elutes nitric oxide. It's the same flux units that vascular endothelium does, just at the surface. And the argatroban is a thrombin inhibitor right at the blood contact. So that's actually this third inner layer. And since the oxygenator cannot be coated, or you would have ineffective gas exchange, in Dr. Bartlett's lab, they have developed an electrochemical NO generator, which allows NO gas in the sweep gas to anticoagulate locally the blood in the oxygenator. So I'm going to share with you very briefly here some preliminary data that's really breakthrough work in the last year that hasn't been published yet. We have 5 animals at about 118 days, which is equivalent to a 24-week human infant in terms of lung development. We did an exit procedure, went directly to the AP using the NOSA coding and system with no systemic anticoagulation, and our goal was 7 days of support. We were very interested in measuring any systemic effects, the ACT, the coags, and we did some flow cytometry looking at markers of platelet activation and leukocyte activation. And then, of course, we also looked at levels of methemoglobin. So I'm not going to show you these graphs, but we had 5 animals that survived for 7 days, the full time. Fetal circulation was maintained with hemodynamic stability and normal fetal gas exchange. This is a representative, some representative pictures of the oxygenator and the circuit. We had no bleeding or thrombotic complications, and you can see from this picture that it looks squeaky clean. The ACT was 189, the mean, versus 257 with the heparin controls, and this is high normal for sheep. When we looked at platelets, there was a decline in the first 48 hours, but this stabilized and slowly increased. The PTT and INR were normal. And when we looked at, hold on a second, P-selectin, which again is a marker of platelet aggregation, it's important to note that these were all normalized for the cell count. And you can see we represent this as a percentage of baseline, and it was actually below baseline. When we look at CD11B, which is marker of leukocyte activation, we had a slight increase, and this came down to normal. And for the granulocytes, similarly. The methemoglobin levels stayed low and stable throughout. So in conclusion, the NOSA system is very promising, surface-based anticoagulation, which certainly has application to the artificial placenta, but there's a number of potentially huge spin-offs, including any type of extracorporeal support, such as ECMO or CPB, and of course, any indwelling vascular catheters. Thank you very much. Oh, I'd like to acknowledge, of course, Dr. Bartlett and Dr. Meyerhoff that I mentioned, who worked on the NOSA system for many years, and my postdoc fellow, Brian Fallon, who did all this work in the artificial placenta model. And this is just a short list of some of the key participants in our lab for this particular project. Thank you very much.
Thank you, George. Fascinating work. And I think will tie well with the rest of the discussions you're going to have today. So now let's move on to Dr. Alan Flake. Oh.
See my screen now?
Yep, beautiful.
Great.
It's a movie.
Yeah. So Mike, thanks very much again for the invitation. I'm really sorry we can't all meet in San Francisco and enjoy each other's company as usual, but thank you for inviting me here. I have a few disclosures. I have patents in this technology, and I'm a paid consultant now for a company, which will be part of the presentation. Unfortunately, that also means I can't tell you a lot about what we're doing. So they put a lot of restrictions on me in this presentation, but I will do my best to give you a general overview in any case. And George just did a great job of summarizing the problem. I'm not going to redo that. I'm also not going to present a lot of the things I've presented in the past few years. I think we can all agree that the problem hasn't gotten a lot better. And I believe, as George just outlined, that it's related to developmental blockades in our current technology. So they're not just small preemies, their organs are developmentally immature. And the best example of that, of course, are the lungs, where they're in the canalicular phase of lung development, and any form of gas exchange or any form of gas ventilation arrests them in that phase. And so that's just one example of a developmental blockade in our current ability to treat these patients, but there are others as well. And we feel that fluid is a very important component of normal fetal development. It goes beyond the lungs even. It includes providing trophic factors, nutrition, temperature-controlled environment, protection of the fetus from heat loss, etc. So there are a lot of reasons that we favor a fluid environment and think it's an important component of an artificial womb system. There have been lots of efforts to make artificial placentas, as you know, and these are some of the blockades that have prevented success, at least up until recently. And one is obviously heart failure. That's the most common mode of failure in historical experiments related to preload or afterload imbalance. And our solution to that has been a pumpless AV circuit. This depends on a very low resistance oxygenator and depends on the pressure drop for flows that are present with the oxygenator. Our findings with this have been that we can support fetuses for prolonged periods of time. It's very durable. We've had remarkable hemodynamic stability in these animals. And we've done quite a bit of experimental work in oxygenator design and specifications that are required for various flows in terms of volume and resistance. And our conclusion from all that is it's possible to design oxygenators for any size fetus, down to obviously certain limitations, but with appropriate specifications, the fetuses can remain very hemodynamically stable throughout their run with physiologic blood flows. The other problem has been infection, of course, and that's really a simple problem to solve in our view. And we've addressed it using a closed biobag system with continuous fluid exchange. We initially tried to recirculate fluid, and that inevitably led to infection problems. And since we've developed the biobag approach, we really had no issues with sepsis. That couldn't be easily explained by a break-in in a sterile technique or required entry into the bag for one reason or another. So overall, I think the infection problem can be managed very effectively in a closed fluid environment with fluid exchange. And then the final one, of course, was the use of the umbilical arteries and umbilical veins, challenging due to spasm in the vessels and their vascular integrity. And our approach to that was to use very short catheters, not to have catheters within the vascular system that could erode or induce spasm, and also obviously to have fetal physiologically balanced blood on institution of circulation, which is very important to prevent spasm, temperature control of your circulating fluid, all of those things, and sometimes a little papaverine on initiation of circuit flow. So with those interventions, we've been able, in the sheep at least, to have runs that are relatively free of spasm or acute flow disturbances related to the umbilical vessels. really hasn't been a significant issue. So that's the current system in the animal world, and we've described it before. I just want to emphasize that this is very reproducible. It's very physiologically durable. We've published a lot of data and a lot of different papers at this point related to it. I won't go through them all at the present time. But for instance, you can even run fetuses at about 2/3 of normal oxygen delivery, produce a hypoxia model, and run it for 21 days in this system. And the sheep have very interesting changes related to chronic hypoxia, but they survive and they maintain fairly physiologic blood flow throughout the experience. So it's not a fragile system. It's not one that doesn't physiologically withstand a lot of manipulation, etc. So the question is really, how do you get from this stable, developmentally equivalent, at least from a lung perspective, lamb model to the human system? And this is just an artist's depiction of a human in one of our pods. It's not the modern version. I can't show you that, but let's suffice it to say that we've made a lot of progress over the past few years in development of a human device that can support a human fetus similarly to the sheep. So this is just kind of the milestones in the timeline that we've been on. We really started in 2013 with the AV pumpless circuit in older fetuses. We created the biobag in around 2015. Started having meetings with the FDA in 2017. Published it in 2017 as well. And then an important milestone was getting breakthrough device designation with the FDA, which has really been very helpful. And finally, CHOP formed a company around this technology in October of 2019. It currently has about 25 employees. It's important to have people and know what they're doing when you're developing clinical devices, as you all know, and that's what we've developed is a cohort of really good people that know what they're doing. They've really accelerated progress with respect to development of a device. So the breakthrough designation was very helpful. We have scheduled sprint discussions with the FDA to clarify their requirements and thoughts on the developing device. We've had a very stable review team, which has always been a problem with the FDA. So we're talking to the same people repeatedly. And they actually seem to want to have this device succeed. They've been very helpful and very facilitating in terms of their interactions. And they've also recognized, I think, that there's no animal model that can perfectly replicate putting a human on the device. And they anticipate a balance between pre-market and post-market clinical data requirements. So they've agreed that a lot of the development of the device will be on post-market assessment. The requirements are to generate preclinical data adequate to support a first-in-human trial, to design and manufacture a clinical prototype device, and design the clinical trial and submit an IRB application, et cetera. We've moved along pretty well with that. The first thing was they wanted us to do a GLP-like study, replicating 3 to 4 weeks support of developmentally equivalent lambs, but to do it in a GLP-like fashion, which we don't have the ventilation system for GLP and CHOP, and so that was the exception to GLP. Otherwise, we've been able to replicate GLP conditions in the laboratory, and we've completed that study, I think, with very good results in terms of organ development and able to replicate the data that was in the original paper. Along the way, they've recommended multiple bridging studies, and a lot of this has been a two-way effort. They don't know how to test oxygenators, for instance, in this kind of a system. You know, what are the requirements for oxygenator performance, et cetera, for a 28-day run in an artificial womb. So we've had to work together on some of these, and most of the bridging studies are related to downsizing of the system, individual components, et cetera. For instance, we have a dual oxygenator system in which we can run human flows in a second oxygenator for prolonged periods, equivalent to what we're anticipating clinically. So we can actually run flows of 50 to 75 cc's per minute and look at the clotting and blood injury problems in the circulation and gas exchange, of course. There's also, we developed a pig model purely to look at human size equivalents in terms of cannulation of the vessels. They have an umbilical cord that is very similar, almost identical to the human cord. And therefore you can actually go through the process of cannulating animals, putting them in the pod and initiating circulation with very good fidelity to what would be done in humans. And just to give you the scale of downsizing required, it's significant, as you can see. And we've been able to run very small animals, 450 grams, for up to 5 to 8 days in the system. They do ultimately have high output cardiac failure, which we think is related to failure of autoregulation and cardiac immaturity in the animals. If you get up to 700 and 750 grams, they seem to have better stability, and we can run those for a longer period. So the clinical prototype device is well underway. Design is complete. We're in the manufacturing phase and the engineering validation phase, and we have working prototypes of most of the system components, et cetera. So we've moved along quickly with that. And the final stages, we've been designing the clinical trials. We have MFM and neonatology advisory groups that are expert in preterm labor, et cetera, and are designing trials that are appropriate for first in human. We plan the first pilot trial to be a CHOP with 5 to 10 patients, then to go to a 5 or 6 center trial for 50 to 100 patients. If you look at the major morbidities and mortality of prematurity, you won't need a lot of patients if you have a dramatic impact with this technology to prove your point. And so we're hoping that after the pivotal trials, we'll have commercial approval to proceed with post-market assessment. And that's all I have. I do have to thank the Children's Hospital of Philadelphia, which has been incredibly supportive of this technology and put a great deal of funding into it, allowing us to get to the point that we're at. And I wish I could really show you all the cool aspects of the human device. Maybe soon we'll be able to do that, but it really is a very innovative device in many respects that replicates the conditions in the womb. Thanks a lot.
Thank you. Thanks for the great update. And to everybody, we're going to have one more talk and then we're going to have a panel discussion. So please use the Q&A feature at the bottom of your Zoom session to tee up your questions for this exciting field. So our next speaker is going to be from UCSF, David Blofeld.
All right, can you guys see my screen?
Yeah, David.
All right. Hi, everyone. My name is Dave Blofeld. I'm one of the third-year Pediatric Critical Care Fellows at UCSF, and I'm really excited to share some of the work that we've been doing here. I am really interested in bridging the clinical and engineering divide, and that's part of the reason I came to UCSF to work with people like Choo on trying to learn how to develop new medical devices and really bring it forward to the clinic. And also, I'm really happy with in pediatric critical care medicine as a subspecialty that really uses a lot of technology to advance the care of children. And so with that, I'll be talking about some of the work we've been doing over the past couple of years on developing a silicon membrane oxygenator for an artificial placenta circuit. It's a device that we've been calling the Cymox. So a little bit of background about the problem. This has sort of been talked about by our other speakers, but we're targeting the extremely premature patient population, those that are born at less than 28 weeks of gestation. And as you've heard before, this is a population with extremely high morbidity and mortality, and primarily due to the chronic lung disease that develops at prematurity, also known as bronchopulmonary dysplasia. And so this is alluded to in the last talk, but in order to understand why BPD develops, it's really important to understand how the lungs develop in utero. And so in this patient population between 16 and 26 weeks, a lot of the lungs are in the canalicular phase of development. This is when these canals are starting to form off the large bronchioles. And one of the things we found is really important, or that others have found that is really important for lung development, is that the amniotic fluid and aqueous environment of the lungs really promotes development and is essential for transition beyond the canalicular phase into the saccular and then eventually the alveolar phases, which is required for mature lung development. And what people have also found is that when you go from an aqueous environment to gas ventilation, you actually arrest development in this canalicular phase and prevent normal development in the lungs. And on top of that, there's the other problem of mechanical ventilation, which is required for gas exchange in these infants, can actually damage the lungs even further. And this is seen throughout patient populations, but ventilator-induced lung injury happens due to volute trauma, barotrauma, biotrauma, atelectatic trauma, and oxygen toxicity. And ultimately, what this looks like is you go from a normal-looking lung with evenly sized alveoli, nice thin septal walls, really excellent for gas exchange, to something that looks more like this, where you have areas of overdistended alveoli and then other areas with thickened fibrotic septae, really poor parenchyma for gas exchange. And for this reason, others, as well as our group, have been trying to develop an artificial placenta. And so what is an artificial placenta? It's essentially an adaptation of extracorporeal life support, or ECMO, or ECLS, all sort of similar terms, and applying this to premature infants. And so, if you look at standard ECLS for full-term neonates, pediatrics, and adults, this has been around, as Dr. Bartlett mentioned, since the 70s. And the technology has improved quite a bit since then. And what it's used for is typically respiratory failure, or sometimes cardiac failure, but in this case as a substitute for the lungs to allow extracorporeal gas exchange in order to allow for lung rest. But in the artificial placenta application, this allows the infant to be submerged in an amniotic fluid bath and allows...
Hey, Dave, I don't think we're seeing your slides.
Oh, you're not seeing the slides. Oh.
We're seeing them frozen. The last slide I see is gas ventilation, arrest lung development.
Oh, okay.
That's correct, guys.
Yeah. Let's try this. How's that? You guys see this? Are you seeing me advance the slides?
No.
Yeah, try stop sharing and share again.
Yeah.
All right. Can you say it now?
We see nothing yet. It's nothing yet.
Huh.
Hold on. It says double click. We are waiting for you to start. It says you have started screen sharing, but we don't see anything yet.
Huh. Sorry about that. I'm not sure what's going on.
Try once more.
If not, maybe you can share. Let's try this again.
All right. Yeah.
Is that working?
Now we see artificial placenta.
How's that?
Yep.
Okay. Sorry about that. I'm not sure what happened, but in any case, so what I was saying is that if you want to adapt an artificial or ECLS to an artificial placenta, it allows submersion of the infant into an amniotic fluid bath, allows the lungs to develop in an aqueous environment. Instead of using the lungs for gas exchange, instead use an external extracorporeal device. And so what this looks like is the infant's heart is pumping the deoxygenated blood out of the body through the umbilical cord to the device, which is interacting with oxygen sweep gas across the semi-permeable membrane. Oxygen diffuses into the blood, carbon dioxide out of the blood, and then this reoxygenated blood is returned to the body of the infant. So, we've talked about how ECLS has been around for a long time, and even the concept of adapting this to an artificial placenta has been around for more than 50 years. And so, and a lot of progress has been made, by others, including those on this conference. But one of the remaining issues remains hemocompatibility. And this is specifically an issue in preterm infants due to the underdevelopment of the cerebral vasculature. So the cerebral vasculature in the premature infants tends to be very fragile and prone to rupture, leading to spontaneous intracranial hemorrhage. This is a big problem in the very youngest infants, and the incidence of intracranial hemorrhage decreases over time as you get closer to term. Now, on the other hand, if you look at also extracorporeal life support in full-term neonates, pediatrics, and adults, what we know is that this requires anticoagulation in order to prevent circuit clotting. And the downside to this is that it actually leads to the opposite problem of bleeding. And in fact, if you look at full-term neonates who have essentially zero incidence of spontaneous intracranial hemorrhage, if you look at those who are on anticoagulation due to ECLS, around 12% of them will have intracranial hemorrhage. And so what this means is that extreme prematurity plus anticoagulation can lead to catastrophic intracranial hemorrhage. And so in order to understand why this happens, it's important to look at the devices that are currently in use for ECLS as well as artificial placenta. And the standard of care is this hollow fiber oxygenator technology. And so, why are these oxygenators, why do they have somewhat poor hemocompatibility? There's a lot of reasons, but three primary ones. The first is that there's a large surface area of artificial material that contacts the blood. And all this artificial material can activate platelets, activate clotting factors, and generally creates a prothrombotic environment. The second reason is that if you were to take apart these oxygenators and look inside at what they look like, this is what it looks like under the microscope. So these are the hollow fibers. The gas goes through the middle of the lumen, and then the blood actually flows around the outside of the hollow fibers and takes this very heterogeneous and turbulent blood flow path. And what we know is that this type of blood flow path can lead to clotting via either areas of stasis, which is known to cause clotting. It also leads to areas of high shear forces on platelets, which can activate platelets and also lead to clotting. And the final reason is that these oxygenators and circuits require large priming volumes, especially relative to the blood volume of a premature infant. And this means that blood is spending more time outside of the body, a concept known as extracorporeal residence time. And the longer the blood is spending outside of the body, the more likely platelets are to become stressed and therefore activated. And so the Cymox really is designed to address some of these issues of hemocompatibility by rethinking the semi-permeable membrane and moving a little bit away from hollow fiber membranes. And so instead of using hollow fiber membranes, our lab has developed a different style of membrane, which we call the silicon nanopore membrane. So instead of using a tubular hollow fiber, flexible hollow fiber, these are rigid plates that are patterned with nanopores throughout it. And so what we do is we take a solid silicon plate and then we pattern these nanoscopic pores, in this case 500 nanometers wide. And then on top of the whole plate, we bond a very, very thin layer of gas permeable silicone, also known as PDMS. And so what we can do is we can take two of these plates and put them in parallel, and the blood runs through the middle of them, which forms the blood channel. And then on the backside, we can pressurize oxygen sweep gas, which can flow through the pores, across the gas permeable silicone, and into the blood. And for the next couple of minutes, I'll talk about some of the advantages of this style of membrane. So the first is that the rigid plates allow us to create short and wide channels. And why is this important? So the first bit is that a short channel is really important, it turns out, to reduce the diffusion distance of the blood channel and actually improve efficiency. So it turns out that the height of the blood channel and the diffusion distance within the actual blood channel is a major determinant of oxygen flux. And so by taking the channel and turning it from this tall, wide channel to a very short channel, the diffusion distance through the blood channel is much shorter. And this is really only possible with a rigid membrane, because if this were a flexible material, this would start to collapse as you narrow the channel. Now, the second piece is that a wide channel can allow us to reduce the surface area. So instead of having a lot of these narrow channels, instead what we can do is we could take away all this supporting material and widen the channel, which ultimately reduces the surface area to volume ratio and therefore improves our hemocompatibility. So the second advantage of SNMs is that it allows us to precisely define the blood flow path. So I mentioned earlier that the hollow fiber membranes have a very heterogeneous and turbulent blood flow path. And so instead, a parallel plate path allows us to create something that looks more like this with laminar blood flow through these channels. And then we can actually use computational fluid dynamics to really model how the blood is flowing through the channels and model shear forces and minimize areas of stasis as well as high shear. And then ultimately we can create stacks of these SNMs with channels defined between between two parallel plates. And then this can be placed into a housing that was designed with computer-aided design and computational fluid dynamic modeling. And the final advantage of using a rigid plate is that it allows us to improve our efficiency for two big reasons. So the first is that because we have a mechanically robust backbone, we're able to use an ultra thin layer of the silicone, in this case only 5 microns thick, which is an order of magnitude thinner than most other all silicone microfluidic lungs. And the second reason is that we're actually able to pressurize the sweep gas. So we've done some experiments with our membranes looking at the burst pressure for them. And it turns out the membranes are able to withstand more than 50 PSI without bursting, without bubbling, or without breaking. And what this means is we're able to increase the oxygen diffusion gradient to further improve efficiency. So I'm going to talk a little bit about some of the data we've gotten in the miniature oxygenators. So this is what we do in terms of testing our oxygenators. So this is an extracorporeal pig study with 3 different devices. These devices we've tested both in water as well as pig's blood. And so this is some of the data from a pilot study that essentially shows that we're able to indeed achieve some degree of oxygen flux across our membranes. So with this encouraging pilot study data, we then moved on to trying to improve our efficiency. So I mentioned earlier that having a very short channel is really important for improving our efficiency. And so it turns out that when we went from 1,000 micron channel height down to 500 micron channel height, we were able to improve our flux by about 30 to 40%. And then further, we tested our membranes with increasing sweep gas pressure. And so this is an example of a membrane that we pressurized from 3 PSI up to 30 PSI. And this was pretty striking. We saw a dramatic improvement in oxygen flux as we pressurized the sweep gas, more than 3 times more efficient. With that, we replicated this across a variety of different styles of membranes. And so this data looks at different membranes and their improvement in flux relative to a baseline of 3 PSI. And overall, we found a 7.5 around increase in flux per PSI. And then finally, we replicated this also in an extracorporeal pig study. And although there was a much higher variance when in a study with blood with our mini oxygenators, the general trend was about the same, where we saw about a 5% increase in flux per PSI of sweep gas pressure. And so finally, I'm going to talk a little bit about some of our goals in building a clinical scale device. So I mentioned earlier that we are able to use computational fluid dynamics to design a device housing with a very nice laminar blood flow and chemocompatible blood flow path. So this is an example of a device housing that we designed with that strategy for an application in an implantable artificial kidney. So as you can see, this is a compact device. It holds about 40 SNM membranes. We've actually also taken these devices and implanted them into pigs who were not anticoagulated for up to 15 days and found that the devices remained clot-free without and had a patent blood flow path. So some evidence in support of the concept that if you design the blood flow path really nicely and in a hemocompatible way, you can really perhaps reduce the anticoagulation needs. And so finally, some ongoing work is that we want to actually build and test a clinical scale device to show we can achieve sufficient oxygenation to actually support a preterm infant, and then do some more long-term hemocompatibility testing in minimally anticoagulated or non-anticoagulated animals. And then finally, incorporate this into an artificial placenta circuit. All the work I've been talking to you about is really focusing on the oxygenator component. But of course, as you heard from the other talks from this session, there's a lot of other components of the artificial placenta circuit. So we'd like to incorporate some of our work into some of these other components and actually be able to test this in an extremely preterm animal model, and then ultimately translate this into humans. And so I'll end with the team that is working on this project. This is the Roy Lab, obviously headed by Choo Roy, who's my PI and mentor. I also have a lot of clinical mentors at UCSF, Peter Oishi, who's the director of our pediatric ECLS program, Jeff Feynman, who's our division chief and runs a fetal lamb research lab, and then Emin, who's a neonatologist and an expert in placental and neonatal biology. And with that, I'll thank you for your attention and look forward to the discussion.
Thank you, Dave. Really exciting presentations by all. So maybe we'll start off with Dr. Bartlett. Maybe you want to start off by telling us a little bit about where you see, the future of pediatric and neonatal ECMO coming up and some of the issues that have to be dealt with.
Well, as I said, there are some 50,000 cases in the registry now, so it's stable, well-established technology, and we're interested in exploring the boundaries like the very low birth weight infant, for example. There will be a need for this technology whenever there are infants and children who have life-threatening pulmonary or cardiac failure. About half of the cases in all ages, including pediatrics, are cardiac support cases, and the way of hooking it up is a little different in those types of cases. In the future, the number one problem is still bleeding and clotting. So some development of developing non-thrombogenic surfaces which avoid the bleeding and clotting is number one research priority. And Dr. Michaliska told you about our approach to that particular problem. The next problem is to develop wearable devices. So now with diaphragmatic hernia patients, and especially chronic BPD cases from whatever cause, they're on ECMO in the ICU for a month or 2 months or 3 months, and they may recover at the end of that, but it's a logistical problem for managing the pediatric ICU. So another major research focus is to develop totally implantable devices so that once it's clear that a child is going to need to be on ECMO support for more than a week, that child can go out to a step-down unit or eventually to home, like some of these diaphragmatic hernia patients who have to be on for 3 or 4 months before they've developed mature enough lungs to develop it. And the third major area of research, you would think we'd be beyond it, but it's really education. Not so much in pediatrics. Pediatricians and pediatric ICU docs and pediatric surgeons understand this. They know when to use it, how to use it, and generally get very good results with it. But when you get into older children beyond adolescents, and especially adults, it's used incorrectly a lot of the time. Despite that, in COVID, for example, as you've probably heard, if you have severe lung failure or systemic sepsis with COVID virus and are dying because of it, those patients do quite well with ECMO support, somewhere between 60 and 80% healthy survival. So that's where the future of this technology is going. It was fascinating to hear Dr. Blauvelt rediscover how to build an oxygenator. We've been at that for some 50 years and the principles have not changed. So that's where I think we're going in the future.
Thank you. There's a question for you, Alan, on the Q&A. They're asking about the cannulation and the time limit to cannulating the fetus. And I'll quote, if there's precipitous delivery, how much time do you have before connecting to your system?
Yeah, good question. One we spent a lot of time trying to address. So first, we're not going to do precipitous deliveries in our first in-human trial. I think ultimately it will be possible to do vaginal deliveries, cannulate on the perineum, clear the contamination that may be involved with that, and do it quickly enough to avoid umbilical vascular spasm. And we have data that you can clear contamination from our device with antibiotics and increased exchange rates. So in the future, that may be possible, and we may be able to take all comers. Until that time, we hope to have a more controlled circumstance, premature rupture of membranes, a woman that comes in, settles down with tocolytic therapy, and then begins to progress again. And that's a well-defined scenario, and one that you can define when labor is irreversible and when to proceed with putting the infant on a device. The time limits on that are really unclear in the human and the sheep model, et cetera. They've been defined by cord clamping, and you've got about 8 minutes and even potentially more in one study before you see evidence of cerebral hypoxia. We don't want to wait that long, obviously, and our goal is to be able to cannulate in less than 1.5 minutes or so of cord occlusion. And, you know, the sheep has 4 vessels. You can take your time. You can do an artery and a vein, and then do the other artery and vein or other artery at your leisure. So sheep are different, but in humans, we've developed a cannulation system. We put a lot of work into it. The system can go from placental to circuit support in less than 1.5 minutes.
Thank you. Dr. Michelesia, could you comment on the nitrous oxide and how that came about to be, and what you see this being implemented in terms of a circuit, and how long it would be applied?
Right, so it's a good question, and I might defer some of this to Dr. Bartlett because he developed it over the last decade. But the idea would be, and I think we have data that the DBHD coating with the argatroban, it would continue to release nitric oxide for several weeks for the period of time that we would be on the artificial placenta, which would be in the 3 to 4 week range. Is that your question?
Yes.
Dr. Bartlett, do you want to say anything else about that?
No. As George told you already, we've demonstrated that it works well for 7 days. Why not go for a month? Those are long, difficult, expensive experiments. And so once we've proved that it'll work for a few days, we're quite sure it'll work as long as the surface is releasing nitric oxide, which we can measure in vitro. And with this particular combination in coating, we know it will release nitric oxide in significant levels for at least a month of time. Part of the key to it is to put nitrogen oxide gas, nitric oxide gas, into the sweep gas of the membrane lung. And of course, you could do that with nitric oxide. It's commercially available and do that. Problem is it's very expensive, as you all know, who take care of babies in the ICU. So the advantage of this NO generator is that it makes unlimited quantities of nitric oxide for very low cost.
So there's a question here from one of our speakers here, Dave. I think this is a question to everybody, but since we have experienced people, maybe we'll start with all of you guys. Who would be the first patients to trial an artificial placenta device, and what age group are we talking about, you think, for some of these new devices?
We plan to target 23 to 24 weekers, so between 23.0 and 25.1. And that's because you look at risk, they have very well-defined morbidity and mortality. You look at benefit over a 4-week period, and most of the benefit can be achieved in that period. So we think that's a logical group to target. In terms of etiology of preterm labor, I mentioned a little bit about that earlier. I think the initial population shouldn't be a chorioamnionitis population, shouldn't be a precipitous labor population, shouldn't be a severe preeclampsia population, should be a probably premature rupture of membranes that is not clinically infected, in which you have a period of labor control prior to progression.
Shuvo, if I could say a few words. This is something that Alan and we have different approaches, and I think the different platforms lend themselves to different approaches. So, you know, Alan's artificial womb or artificial placenta, the AV ECLS approach, it has to be applied from the womb. So my concern about that is that there's no risk stratification for the fetus apart from gestational age. So while we might agree that a 22, 23-week fetus or infant has a very poor outcome, when you start getting to 25 weeks, the outcomes continue to improve. So the VV-ECLS approach that we have been working on is applied after birth, after you have a period of risk stratification. So you might have a 25-weeker who does very well on very non-invasive ventilatory treatment, and that would not be a candidate in our hands for the artificial placenta.
George, maybe talk a little bit about the infection risk on your model versus what, is it very similar to how Alan's addressing it, or do you address it differently?
Well, we address it differently. I think Alan has made a lot of progress in solving the problem of infection in an amniotic fluid bath with his filtration system, and he could talk more about that, but he's demonstrated that and published about that. Our model uses fluid-filled lungs, which is not exactly the way a fetus develops, but we've shown that with fluid-filled lungs to a meniscus, the animals continue to have fetal breathing movements, and we've demonstrated ongoing lung development that looks normal.
I can just say, I think, you know, George's and my approaches are probably complementary. We apply to different groups of patients. The one issue I have with George's approach is that they will be ventilated, and the act of gas ventilation has been demonstrated experimentally, at least, to be associated with canalicular phase arrest. And so that potentially would reduce the impact on BPD. I do believe that at some point we'll be able to expand the application of our technology to vaginally delivered infants. And the question of selection and gestational age really comes down to the risk of the technology. So if the technology can be applied with low risk, then I think it can ultimately be expanded into a 25-week population, for instance. If obviously it has its own set of risks associated with it, then that may not be appropriate. There are also a lot of prenatal approaches coming up, genetic testing, et cetera, which can define the level of risk for fetuses for things like BPD, some of the morbidities of prematurity. Those may be able to pre-select infants that would most likely benefit from the technology. So it's a complex issue, obviously, but I think the two technologies can certainly be used in a complementary fashion.
So with that, I'm going to say we'll have to continue this discussion at the next Harrison Symposium, because it's clearly, this is what panel discussions are for. So thank you very much. Very nice discussion. Great state-of-the-art update. We look forward to sharing again. And now I'm going to hand over to my colleague and friend, Tippy. Next exciting session.
You said Megan decided.
Hi, thank you, Shuvo, and it's just such an honor to be here with all of you, honoring Mike for all his contributions to pediatric and fetal surgery and innovation. So this session is going to be on fetal molecular therapies, stem cell therapy, protein replacement, and gene editing. And so it's my pleasure to introduce my colleagues in this session. We're planning on each talking for about 10 to 12 minutes and then having a panel discussion on the roadblocks to clinical translation. So our panelists are Dr. Diana Farmer, who is a professor and surgeon-in-chief at the University of UC Davis. She is the Pearl Stamp Stewart Chair of the Department of Surgery. And her lab, as you all know, made the seminal discovery that hindbrain herniation can be ameliorated by prenatal repair in fetal sheep. She was a PI on the MOMS trial, of course, and now has a brand new clinical trial on stem cell therapy in spina bifida. We'll also hear from Dr. Bill Paranto, who is an assistant professor of surgery at CHOP, and he's doing beautiful work on gene therapy and gene editing for various diseases, as well as Dr. David Stittleman, who is an assistant professor of surgery at Yale. And David has done beautiful work on using peptide nucleic acids for gene editing for various genetic diseases. So thank you all for joining this session. And with that, I'll hand it over to Dr. Farmer for our first talk.
Well, thank you, Tippy, very much. And it's such a privilege to be here. I will start sharing my screen. And go to, can you see my slides?
Yes, perfect.
Great. So it really is a pleasure to be here, and it's hard to imagine that it's been getting close to 40 years since Mike, you did the first fetal surgery. I had the great, good misfortune of not being able to be directly in Mike's lab when I came to UCSF originally, but he sent me to the poor guy next door who didn't have a fellow, but was doing cancer cellular therapy. Little did I know that that would end up being one of the most important, one of the first of many unanticipated opportunities. So I'm going to talk about taking cellular therapy now to fetal therapy. And my next experience with cellular therapy in the fetus was when I happened to be in Detroit when Alan Flake did his first in utero treatment for stem cell therapy for severe combined immune deficiency. So this group needs no introduction to the fact that the fetus is the ideal place to cure diseases, because theoretically, we could have a long-term fix with just one or two interventions that, if they stick, could last a lifetime. I got involved with spina bifida when I came back to join Mike as a partner, because since it was the first of the non-fatal fetal diseases that we decided to tackle. And picking up on the work that had been done by Martin Muley and Scott Adzik, the foundation for the possibility of doing fetal repair before birth was already set. I always thought that this was really crummy disease, even though kids didn't die from it. You know, all babies tend to be incontinent and can't walk, so the parents don't really know what is in store for them until later on, and it's really a tragedy. We have learned that the two-hit hypothesis is really true, that it's a failure of the spinal cord to close, but that all of the building blocks of a normal spinal cord are there. And as imaging has been advanced, we've been able to see that fetuses are able to move their legs earlier in gestation and that they lose it over time. And it's this secondary damage that causes the problem. So it led itself perfectly to the first trial that was really a nationwide multi-center randomized trial of doing the same operation before birth that we do after birth to see if it made any difference. And of course that culminated in the MOMS trial, which was published in 2011. Now, we all thought that this trial was going to get stopped for slow enrollment. It started almost 10 years before. and lots of challenges along the way, and that's a whole nother talk. But what we did learn, they ended up being stopped prematurely for efficacy, a really rare occurrence in trials and FDA. But the dramatic reduction in the need for a VP shunt is what led them to stop the trial. And it did show for the first time that there was an improvement in motor function. But still 60% of the kids were paralyzed. What I took away from this trial, yeah, it was great about the shunt, but for the first time, spinal cord paralysis looked like it could be helped. If you could get a little bit of improvement, we thought you could get more improvement. It was the first time anybody ever thought you could do something about the paralysis. So I collaborated first with some colleagues. I went to San Francisco General to learn about spinal cord injury from the trauma guys there, and they connected me to a bioengineer at Berkeley, and we started thinking about, would cells make a difference? And there, of course, I realized it was the postdoc in the bioengineer's lab who was doing all the work, who has now been my partner for the last 10 years, Aijin Wang, as we bring surgery, biomaterial engineering, and stem cells together to treat fetuses before birth. So in the spirit of what was said by Sam Hoggard this morning and others, there were many failures along the way, or as they said, the successes, the ability to successfully identify the many things that didn't work. So I'll just flip through that. Nanofiber scaffolds, we thought this was going to be a great idea. You just get the cells to align. The fetus is already regenerating or generating. It's like a petri dish for generation. So all they would need was to know where to go. That didn't work. Then we thought, well, neurocrest stem cells, that they're what form the spinal cord in the first place. Maybe we need to replace some of those missing cells. And we actually did get engraftment with iPS-derived neurocrest stem cells. So we sort of engineered a neural lineage, but it turned out it looked like we probably really didn't need to do that. And the minute you start thinking about it, long-term engraftment, you've got lots of other things to think about. So we thought, oh, the amniotic membrane, that'll work. And it's already been used for protecting the cornea. What a great idea. We actually tried that kind of accidentally in a patient once. It looked like a great idea. So we took it back to the sheep lab and it was great, except it was so anti-inflammatory that the skin didn't heal. So that didn't work. So the placenta has always been, really the most understudied and incredibly interesting organ. I mean, here in 9 months, it forms blood vessels and it protects the fetus, and it's just amazing. So at the time, chorionic villus sampling was actually being still done for diagnosis. I was pretty confident stem cell therapy was still pretty controversial, that a mother was not going to let somebody else's stem cells into their baby. So I thought we need an autologous source of stem cells. And by targeting the placenta, there was a lot of tissue there. It's fetal in origin, but you wouldn't actually have to you wouldn't have to biopsy the fetus or biopsy the skin. So we said, okay, let's work on the placenta. So we identified the mesenchymal stem cells from the chorionic villus area and learned a lot of amazing stuff about these cells. First of all, they were able to be expanded very rapidly, more rapidly than we could at the time with amniotic fluid cells. When we cultured them in our special sort of neurogenic media, we were able to not only see the usual mesenchymal lineages, but also evidence that they might even be able to be coaxed down a ectodermal lineage as well. Now, this is controversial, but got us excited that these cells were different. Their cytokine array was impressive, and compared to adult bone marrow stem cells, it was very different in terms of the extracellular vesicles, the cytokines than we would see, and particularly BDNF and HGF that were well known to be neurogenic factors. So we stuck with the placenta and we went back to the sheep lab. We modified the original model so that we could just close the defect with skin as our control, the way we were now treating human fetuses. And it's amazing how similar that model is. The spinal cord is exposed, so the human's on the left of the screen, the sheep on the right. And we just did the same operation, except we put our stem cells in this hydrogel, because I knew we needed something like a glue so they'd stay there long enough for us to do the repair. You couldn't just, squirt them in with saline. So we used a collagen hydrogel at the time, and we had a twin pregnancy. And so one lamb just got the hydrogel and the other fetus got the hydrogel with cells. And it was just mind-blowing. The fetus that got the cells was able to walk completely. You can see that little scar on the fetus's, on the now newborn lamb's back. Baby lambs have to walk when they're born because they have to walk in order to nurse. And I promise you, if human babies had to walk when they were born in order to nurse, this disease would have been cured eons ago but nobody was particularly excited about spina bifida, right? Neurosurgeons go into neurosurgery to do brain tumors. It's not really a pediatric surgery thing, but it's a crummy disease. So then we had to start learning, like, oh my gosh, this looks like it could work. How do we assess it? We came up with the Lamb locomotor rating scale. We had to learn all about the hips and where the ankles and where all the joints are in four-legged animals, and came up with a score. We didn't exactly know how it worked, but it appeared on histology. It didn't restore the form of the spinal cord, but it looks like it prevents it repairs apoptotic loss and restores large motor neuron density almost to normal. So then we got preliminary funding from CIRM to do preclinical work. Did we just get lucky? Was it just this one magic placenta, or could we really do this if we engineered any placenta with our neurogenic growth system? So we got 3 more. This is all GLP work now, 3 more cell lines. And we developed an in vitro neuroprotection assay with a SY5Y neuroblastoma cell line to see if we could protect from apoptosis when we used our cells. But we realized we had a problem. This is all looking good. We're feeling like we can get the cells, but collagen at the time is made from rat tail. And for some reason, the FDA is not a fan of rat tail collagen. And we knew we couldn't use that. There were no FDA approved collagen available at the time. We actually licensed a product that we made, and now they're making face cream out of it. But so we said, we got to find some way to deliver our cells. So we went to an already FDA approved dural graft, because we knew that in the MOMS trial, we had used some of these patches when we didn't have enough dura to close. So we had to find out, did our cells grow on this stuff? Turns out they did. We had to measure the viability and the loading density and how did they do. We then had to do dose optimization studies, which we first did, how tightly should we put the cells on this stuff? We first did this in a rat model, and then took that rat model back into the lambs. And now we were able to, now you can see all those little dots there, the red and the blue and the purple, those are all fetal lambs. We have done a lot of fetal lamb surgery, over 100. Then you can see this is sort of the results over time, and that we identified that the optimal dosing, and in fact we thought, well, let's test this concept. We found out that dogs actually get spina bifida naturally, sort of a version of it. Most of the time they're euthanized by the breeders, but the top picture here is a human covered spina bifida lesion, very similar to the dog. So we had to learn a lot about dogs, but Aijin Wang, my bioengineering partner, kind of led this study. And you can see this dog kind of walks on its hocks, its whole feet, and sort of a little bit discoordinated. And here you can see up on its toes and much more active work in these bulldogs. So with the help from CIRM, we got additional funding to go from the GLP level to the preclinical study work and the FDA IND enabling studies. We got placentas that were now from mothers who donated their placenta. We generated the cell lines now in our GMP facility at UC Davis so that we could do it under near GMP quality. Did all the endotoxin testing, all the sterility testing, and identified 5 cell lines that we expanded to product banks and then tested those. So the process is that you take the placenta, isolate the chorionic villi, bank them in clinical grade GMP facility, and then expand them and culture them ultimately on the ECM. 17 placentas were collected. We generated the cell lines in our manufacturing process. We characterized these carefully because this is going to be a first in human mesenchymal stem cell in a fetus. So we had to make sure that these were indeed mesenchymal stem cells. So they show all the mesenchymal markers and none of the hematopoietic markers. They do not demonstrate pluripotency. We don't want these cells to last. We want them to go there and deliver their sort of magic stem cell juice and then be gone. We identified these were our 5 cell lines, and we ultimately got it down to 2 cell lines that were very similar in almost every characteristic and had the highest secretion of BDNF and FGF and HGF of the 5 that we selected. At the end, the only way we could pick them a difference was because of the donor was CMV negative, cleared all the WuXi viral testing. This was pre-COVID, so we tested for Zika, but COVID wasn't there. We've actually now manufactured about 5,000 doses of this because you don't need very many stem cells for a topically applied material to the little baby fetal spinal cord. So we finished with mouse safety studies and identified that there was no tumorigenicity in a mouse, an immunodeficient mouse. No evidence of human DNA, again, collaborating with our vet school for the additional work. And then did the same safety studies again in a large animal. And again, no evidence of human DNA remaining in either of these settings and no evidence of tumor development anywhere in the central nervous system. So we, CIRM, our funder, before they were going to give us the next batch, wanted to know that this actual cell line, so the one we are going to use in human clinical trials, was also efficacious in our large animal model. And so we had to go back and do a few sheep to make them happy. And indeed, we were happy to see that that was indeed the case. So,
Diana, just a quick time check.
Thank you.
Thanks.
So let me just get to the important point. The IND has been submitted and we received approval and we will be starting we have actually opened to enrollment now and we are enrolling patients. We will do 6 patients as part of the initial safety study. The FDA is making us do them sequentially, so the baby has to deliver before the next one. So we'll only do 3 patients a year for the first 2 years. And then assuming we pass that test, which we think we will because we've done like hundreds of lambs, we'll go on to do the additional 29 patients to evaluate for efficacy. So we're excited about having gotten this far and very grateful for CIRM to have funded this difficult effort to get all the way to first in human studies. Thank you.
Thank you so much, Diana. That's really incredible. And I'm sorry I had to do the time check. I know this is just an incredible journey from the mom's trial to what you're doing now. So next, I'm going to just speak briefly about some of the fetal molecular therapies we're launching at UCSF. So these are my disclosures. So I've started to think about innovation in fetal surgery as sort of this spectrum between anatomic and genetic diseases. And just like ultrasound really enabled fetal surgery because you could sort of peek in on the fetus and see these anatomic problems, we're now able to see more genetic diseases with genetic testing. And so if you sort of think about anatomic problems and fetal surgeries that we do for those, hydrops ends up being this in-between condition where there's an anatomic problem, but there's an anatomic manifestation of a genetic disease like alpha thalassemia, et cetera. And then in an age when we're hopefully going to start doing prenatal genetic testing, the dam will hopefully break open, and that opens up all these other genetic diseases like the thalassemias and lysosomal storage diseases, et cetera. And of course, as everybody here knows, the reasons to treat the fetus are that you could tolerize to new proteins, protect the brain before the blood-brain barrier has formed, and access stem cells during their migration. So in terms of what we're doing at UCSF right now, as you know, we have a phase 1 clinical trial of stem cell transplantation for alpha thalassemia major, and we're trying to expand to other similar diseases. We're just launching a new clinical trial of in utero enzyme replacement therapy for lysosomal storage disorders. And we're in discussions with the FDA and patient advocacy groups and ethicists regarding carving a rational and ethical pathway for prenatal gene therapy. So alpha thal major has become my favorite disease. And as you all know, as adults, we all have alpha and beta globins, but as fetuses, we had alpha and gamma globins. And if you're a fetus with all 4 alpha genes deleted, you make these gamma tetramer hemoglobins that just don't work. They don't deliver oxygen, and the fetus develops hydrops, the harbinger of fetal demise. And we thought this was a great first disease to do the clinical trial on because the fetuses already need transfusions, so there's an ethical rationale to give the HSCs. So in our current clinical trial, we're transplanting maternal bone marrow-derived stem cells because we know that the fetus should tolerate the mom. 1% T cells added back in, and we're continuing transfusions every couple of weeks. So here's how it works. Mom goes to sleep under spinal anesthesia. We do the standard bone marrow harvest, and then they select out the CD34 cells, and then we infuse them back into the fetus at the time of an in utero transfusion. And you can see the infusion there. It's an ultrasound guided transfusion. Juan Gonzalez, who's our MFM, has been doing these. So we transplanted 3 patients so far, and 2 of them have finished the 1-year follow-up. The 3rd one we just transplanted, so they're still in utero. 2 of them presented with hydrops. They improved with in utero transfusions, and we give them a whopping dose because we're not currently giving anything to wipe out the fetal bone marrow to improve engraftment. We haven't had significant safety issues with the first 2. The 3rd one, we kind of had a scare of a positive bone marrow culture, which turned out to be a lab contaminant. We haven't seen preterm labor with the first 2 patients, and they've done well normal neurologic testing at 1 year. And in terms of efficacy, we've seen low levels of engraftment, but we did see tolerance to maternal antigens seen in 1 patient, which was really one of the main endpoints that we were looking for. It means that we could potentially do a postnatal bone marrow transplant to achieve definitive levels of chimerism. We've been thinking a lot about alpha thalassemia and why there's, the textbooks all say it's fatal. And we've been doing a lot of work with an international registry that we started looking at survival and neurologic outcomes. This is led by Marissa Schwab, who's a surgery resident in the lab, and Billy Leognolu, who's our genetic counselor. And you can see that patients who had adequate in utero transfusions tend to be born near term. They have short hospital stays. And when we do the Vineland neurological testing, there's a beautiful correlation between the age that you got at which you got your first IUT and your neurologic outcome. So we do think it's reasonable and ethical to offer fetal therapy to patients with alpha thal major. And this is kind of my new thing that I'm nerding out on, is sort of the basic biology of alpha globin. And we're finding that spontaneous survivors of alpha thals, these sort of miracle kids who nobody knew they had alpha thal major, but then they're born spontaneously, usually a little bit preterm. They have intact zeta globin, which is the precursor. So before all of us as fetuses, we started making alpha globin, we were making zeta globin. And some of these alpha thal deletions delete into the zeta locus, but some don't. And when we look at our registry patients, the ones who were diagnosed prenatally because they were sick, about a quarter of them have zeta deletions, but these miracle babies who are born spontaneously, none of them has a zeta deletion. So we're wondering whether we can actually upregulate zeta to compensate for the loss of alpha globin, just like people are doing for sickle cell and beta thalassemia. So this is now an active area of research in the lab, and I could sort of nerd out on it forever, but I'm going to keep moving. We're also recognizing that alpha thal is an urgent public health issue and really a health equities issue, because we're meeting, the more families we meet, the more we understand that they really haven't been given standard of care pregnancy options, namely transfusions. So we've started a patient advocacy group. We just had an international meeting, and we've even made a mini documentary that we're disseminating now on social media. And switching gears to our new clinical trial, this is for prenatal therapy for lysosomal storage disorders. You all know that these are genetic diseases with critical deficiencies in critical lysosomal enzymes, currently treated with recombinant enzyme or stem cell transplant. And there's a very good rationale for prenatal therapy, because you can prevent in utero demise, you can induce tolerance to the missing enzyme, which ends up being a huge issue with postnatal therapy, and you can deliver the enzyme into the brain. So we did this in mice. As Dr. Flake once said, you know, fear not if you're a fetal mouse with any genetic disease, you can be cured with prenatal therapy. And so we cured a bunch of MPS 7 mice and showed that they were tolerant, they could survive to birth, and we could treat their brain disease. And based on this, we've developed an in utero enzyme replacement therapy protocol after having a lot of conversations with national experts. My partner in crime here is Paul Harmatz, who's an amazing pediatric geneticist here, as well as, again, Marissa, who wrote the protocol for the FDA. And our IND has been approved, and we're just launching our phase 1 clinical trial now. As I mentioned, we've engaging the patient community. We think that many of the patients are going to be patients who already have an affected child, and that's why they had prenatal genetic testing, because we're not using screening for these disorders. And so when we ask these parents, what's your likelihood of ending a future affected pregnancy, the majority of them said they were unlikely. And what's their likelihood of choosing fetal enzyme replacement therapy if it were established and safe? Majority of them said they were likely. And even when framed as a phase 1 clinical trial, the majority of them said they were likely. And again, on social media, you sort of see all these encouraging comments. So we were able to get blanket approval from the FDA for 8 different related lysosomal storage disorders, which we think will be diagnosed by, again, with carrier screening. We're going to do the enzyme replacement therapy through the umbilical vein every few weeks, because that's the half-life of the recombinant enzyme, and then do standard postnatal care and yearly follow-ups here. And these are our objectives: safety and feasibility. And then the secondary objectives, of course, would be efficacy. And, you know, our real goal, of course, is prenatal gene therapies, which are going to be kind of a definitive cure. We're right now very interested in antisense oligos, which act at the RNA level. So it sounds less scary for us and for the FDA for a fetal therapy. And there are some FDA approved therapies for SMA and one that's being developed for Angelman. So those are actively being tested in the lab, as well as a gene therapy approach for spinal muscular atrophy. And we just started a collaboration with Dr. Farmer, actually, to do fetal sheep studies using that vector. The regulatory considerations have been very interesting. The FDA has definitively said they will only give approval for something that's approved in the postnatal setting first. And you have to have a prospect of benefit even for a phase 1 clinical trial, which is quite a high bar. And we've had a lot of discussions about the ethics of doing fetal therapy for a disease and taking on the risk of that umbilical vein poke for a disease that's not embryonic lethal, and, you know, for a fetus who doesn't otherwise need a fetal intervention. So those are sort of ongoing discussions. So I'll stop there and acknowledge the army of people who contribute to this work, both for the thalassemia and enzyme replacement therapy teams, as well as the basic science lab. And thank you so much. It's going to be Bill Peranto next.
All right, so thank you very much, Tippy, for inviting me to speak here today. It's an amazing opportunity, and the whole day has been great. It's been very inspirational. So I'm just going to dive right in and speak a little bit about the work that we're doing for prenatal gene editing. And so this is the problem. I'm not going to go into it in much detail. We all know the problem about birth defects. I'll just highlight that within this category of birth defects, there are a subset of patients that have single gene mutations that account for a significant amount of morbidity and mortality, especially within the pediatric population, and that these diseases would potentially be great targets for prenatal gene therapy and gene editing. And this is a slide which I think many of us attending have. I've stole it from Dr. Flake, but the point is that there have been huge advances in prenatal diagnostics to the point that most anatomic and now genetic abnormalities can be diagnosed before birth. And obviously, Dr. Harrison is the father of fetal surgery for a lot of these structural birth defects. And what we are very excited about as a future area of intervention is a prenatal gene editing, in which, in a minimally invasive approach under ultrasound guidance, similar to what Tippy just described for enzyme replacement therapy, we could deliver a viral vector editing technology, which could ultimately provide a one-time, long-term cure of a genetic disease before a baby is born. And so what we use in the lab to evaluate this is we use the CRISPR-Cas9 editing system. Dave is going to speak after me, and they use a slightly different approach. I'm not going to get into much details, with the exception of mentioning that there are three main approaches of using CRISPR-Cas9 for editing. One is to use non-homology end joining, in which you could direct the Cas9 to a specific site in the DNA to make a double-stranded DNA break, or to cut out a segment of DNA, which could eventually silence or delete a disease-causing gene. The other approach is to deliver a homology DNA repair template together with the Cas9 and the guide RNA to target the site in the genome that you want to fix. And in this case, when the cells repair the DNA break, they could incorporate the correct DNA sequence, fixing an underlying disease-causing mutation. And both of these approaches are great, but they require making double-stranded DNA breaks, and homology-directed repair requires the cells to be cycling. An alternative approach is one called base editing. This was developed by David Liu at MIT. And in this case, he's joined base editing proteins with the Cas9 and the guide RNA so that you could direct the base editing protein to a specific site in the DNA. And depending on the mutation you're trying to fix, you could switch a C to a T or a G to an A, and vice versa, depending on which base editing approach. The importance of this mechanism is that it doesn't require proliferating cells. It doesn't make double-stranded DNA breaks. And so in theory, it's safer and more efficacious than traditional CRISPR-Cas9. And so Tippy always advises me to put this in my talk just to highlight that what we're talking about here is fetal gene editing and not early embryo gene editing, both of which carry with them ethical questions. The early embryo gene editing may carry more ethical questions. We focus on mid to late gestation fetal gene editing. So why would you ever do this? This is the rationale that Dr. Harrison and Dr. Flake I've heard them speak about many times, and Dr. Flake has taught me. And it boils down to some basic developmental properties of the fetus that may make it more efficacious and safe to do gene editing before birth than after birth. One of the most beneficial aspects is that the fetus has a lot of stem cells that are more accessible than you have after birth. And ultimately, like Dr. Farmer had mentioned, the goal is that you could have a one-time cure before the onset of irreversible pathology that you can't treat after birth. And so with this rationale, like Tippy mentioned, you could imagine applying this strategy to a number of different diseases. We are focusing predominantly on genetic lung diseases as well as multi-system diseases, including neurodevelopmental diseases. And so in the lab, through many years studying with Dr. Flake, we have two main mouse models to deliver this gene editing technology. Oh, sorry. One is an intravascular approach, and one is an intraamniotic approach. The intravascular approach can target the liver and other organs, and the intraamniotic approach can target the lung. And so using this mouse model of delivering gene editing material, we initially sought to see, is it even feasible? And to do so, we decided to look in a mouse model of hereditary tyrosinemia type 1. So this is a metabolic liver disease that has an incidence of about 1 in 100,000, but a higher prevalence in parts of Canada due to a founder effect. It results from a mutation in the FAH gene, and as a result, you have an accumulation of a number of toxic metabolites upstream of the mutated enzyme. And this accumulation can cause liver and kidney pathology. Without treatment, kids can die by 8 years of age and or have hepatocellular carcinoma. Luckily, there is a good treatment for it. It's a drug called NTBC, and this drug works by inhibiting the HPD enzyme upstream of the mutation, and so you can prevent the accumulation of these toxic metabolites. There are some limitations to this. Some patients don't respond to it, and there's a question whether or not there's a continued risk of hepatocellular carcinoma. So our question was whether or not we could use base editing to essentially take the place of NTBC and introduce a nonsense mutation in the HPD gene, resulting in a single one-shot long-term treatment for hereditary tyrosinemia before birth. So in a first step, we screened the sequence of the HPD gene and identified codons that could be changed from an amino acid to a stop codon using a cytosine deaminase base editor. We looked at a number of different codons, and the bottom line is we were able to find two that seem to work very well in vitro. And then there's a very nice mouse model of this disease in which you can mate homozygous mice and keep them on this drug, and they survive fine. But when you take them off of the drug, they will die. And so in our system, we mated homozygous mice and injected the fetuses of these mice with an adenovirus containing either the base editor or a control virus. And then when the mice were born, we took them and put them with a foster mom that wasn't receiving the drug. And so if they survived, it was a good, easy assay to see whether or not the editing worked. And so what did we find? So as you might expect, we were able to see some relatively good editing in the liver that increased over time, which speaks to the survival advantage of the corrected cells. And those mice that underwent editing had good weight gain and good survival that was equivalent to mice that were maintained on the drug. When we looked at the liver function of the edited mice was also normalized compared to diseased mice that didn't get treated. And as you might expect in this lower panel, we stain for the HPD protein, it's stained brown, and you can see when we edit it to silence its expression, we see the loss of protein expression, which just confirms biochemically that we were doing what we thought we did. So this was great, but I remind you that we did it all with an adenovirus because adenoviruses work very well, and you can package these large transgenes easily in an adenovirus. But adenoviruses are not without their. And so the next step was to see if we could deliver it in a more clinically relevant delivery vector. And so we've more recently turned to looking at AAV delivery as well as lipid nanoparticle delivery. In AAV, not surprisingly, like they've shown for postnatal AAV8, we've shown that prenatally we can target the liver with AAV8 expressing a GFP. The lipid nanoparticles were a little bit more complicated because I'm not a bioengineer, but we had a very good and fun collaboration with somebody in the bioengineering school at Penn. And we've created a library of different lipid nanoparticles and screened them to see which one could target the fetal liver after in utero injection. We found some good candidates, and then when we looked at their toxicity, we found that they were not toxic to either the fetus or the mom, which obviously is important when we think long-term down the road for clinical application. And then finally, we went back to this mouse model of tyrosinemia, and we tried to deliver the Cas9 and the guides targeting the HPD gene either in an AAV or a lipid nanoparticle. And we were happy to find out that these delivery approaches also were able to reverse the lethal pathology in the mice. And so that's just a little bit of what we're doing in the lab and where we think things are going. The whole point is in these early studies, we've just been able to demonstrate the feasibility of gene editing in the mouse model and the ability to correct some human diseases. Like I said, we're looking actively at alternative platforms, which will be clinically important for delivering this technology. We've started some large animal models in sheep as well as in canine models of diseases. And then it's important to highlight for any gene editing approach, because the guide is specific to this the specific DNA sequence, it's important not just to do it in mouse models or animal models, but you have to do some humanized systems to look at the effect of the therapy, both on the target site as well as off-target sites. And so, this was a very quick overview of a lot of work over the past couple of years, which were done by a lot of people in our lab and some very good and close collaborations with people at Penn. And I obviously have to acknowledge both Dr. Adzik and Dr. Flake. I think this was, in Candlestick Park, maybe when they were in San Francisco, not too long, or a couple of years ago. Dr. Flake has been an unbelievable mentor to me ever since I was a medical student, and I met him in 1999. And I still enjoy and value his advice today. So thank you very much.
Thank you, Bill, for sharing that. Thank you so much. And Dave Stittleman.
You can see my screen?
Yes, perfect.
Excellent. So thank you for the invitation to be part of this panel. It's a real honor to be here. And my introductory slides are very similar to Bill's and Tippy's. That comes from Alan Flake's teachings, which came from Michael Harrison's teachings. So these are my disclosures. My translational laboratory, like all the ones on this panel, seek to treat and cure diseases before birth. This is a collaboration with experts in biomedical engineering and molecular therapy. And then the undergrads, medical students, graduate students, and surgical residents are really the lifeblood of this work. This is my favorite slide to illustrate the bad luck of genetic diseases. So this is an exhibit from a modern art museum in London where the artist printed the human genome in size 8 font. So each chromosome got a handful of volumes. And to realize that this information is in each cell is staggering. And to realize that one typo in this whole thing, and you get one of these, one of the 6,000 known genetic diseases that impact 1 in 200 children. So, as has been stated, the first question is, can genetic diseases be diagnosed before birth? And the answer is yes, as fetal DNA can be acquired through chorionic villus sampling, amniocentesis, and in the maternal peripheral blood. The next question is, why attempt to treat genetic diseases in the fetus? So the first compelling reason is that for diseases with a developmental component, you may be able to reverse the disease phenotype and allow tissues and organs to develop more normally. And this has been validated by the experience with several fetal therapies and fetal surgeries that have been described today. With regard to genetic disease, it's been validated that administration of viral vectors to rescue animal models of lysosomal storage disease works better the earlier you go. The next advantage is that fetal administration may work better. So fetal stem cells and progenitor cells are in a state of massive proliferation and migration. For example, the hematopoietic system. The fetal hematopoietic stem cell is in the fetal liver. So this is hematopoiesis over pregnancy. And that hematopoietic stem cell then migrates to the bone marrow. This is related to the hypoimmune state of the fetus, and these migrating stem cells may be accessible in fetal life. So while in Alan Flake's lab during medical school and surgical residency, I learned how to perform injections in fetal mice using viral vectors with green fluorescent protein as a reporter very, very early in pregnancy. We showed that injection of a viral vector into the amniotic space grants access to neural stem cells. So you can see these green neurons. Later in pregnancy, these cells are covered by layers of tissue and are no longer accessible through an intraamniotic route. This is an example of anatomically accessible stem cells. Another example, muscle stem cells migrate from the somi to the muscle between day 14 and 16 days of a 21-day mouse pregnancy. Deliver viral vectors IV before this migration at 12 days results in green muscle, but no uptake in the muscle stem cells, kind of the right half of this flow cytometry plot. IV injection during the migration at 14 and 16 days results in green muscle and green stem cells. And delivery after birth results in green muscle, but you lose the ability to target the muscle stem cell compartment significantly. Another advantage is the size of the fetus. So this is a chart that demonstrates the fetal size over pregnancy. So we're talking about treating a patient the size of a mango. And this has important implications in terms of the dose per kilogram and the dose per stem cell. And so genetic diseases can be treated with gene replacement therapy, which is not the focus of my talk, but I think it deserves some mention. An efficient means to do this is with viral vectors. And this slide illustrates postnatal viral vector therapy for severe combined immunodeficiency, where blood stem cells are removed from the patient, treated with viral vector to supply the missing gene, and then returned to the patient. It's important to note that this is cheating because this host is innately immunosuppressed, and it's convenient that blood stem cells home back to their niches in bone marrow, and that may not be true for other tissue types. These trials were successful in treating SCID, but unfortunately had a high rate of cancer from insertional mutagenesis of the viruses. To delve a little bit deeper into viruses, this is a cartoon of a viral vector where the expression of a gene product in blue is under control of a non-native promoter in green. So for large genes, you're limited by the cassette size or the size of the gene that will fit into the virus. With these promoters, you can have silencing where the gene does not get expressed or expression in undetected locations. So we turn our attention from gene replacement to gene editing. So my colleagues in molecular therapy at Yale have designed and provided these gene editing reagents in the form of peptide nucleic acids, or PNAs. PNAs are DNA analogs with a protein-like backbone instead of DNA's sugar phosphate backbone. And PNAs are constructed with the same bases as DNA and are designed like a PCR primer to bind specific sequences of DNA. This binding is stronger than DNA-DNA binding and is resistant to nucleases. This is a cartoon that displays how our editing strategy works. I did this animation myself. The black bar represents the chromosome and the frowny face represents the mutation. A PNA is designed to bind near that mutation. The cell's editing mechanisms find the bound PNA, excise that segment of DNA, and then we also deliver a homologous segment of DNA that's modified to correct the mutation. This donor DNA is then incorporated into the chromosome through homologous recombination. And using this method, we're not limited by the cassette size of vectors. The gene regulation remains the way nature intended. This technology is only good for changing about 3 bases, though. So it is not great for alpha thalassemia or larger deletions. So I need to compare this to other editing technologies that Bill described that use exogenous editing enzymes. So zinc fingered nucleases are nucleases, CRISPR-Cas9 and TALENs use exogenous nucleases. This technology with PNA DNA has no innate nuclease activity. So that means that it uses mammalian cells' own editing equipment that may be higher fidelity than exogenous nucleases. And this may be safer for systemic administration. My analogy for how this works is for the PNA DNA editing technique works is that the chromosome is like a Microsoft Word document where the PNA is like the find function and the DNA is like the replace function. And so that's about the limit of my understanding. To facilitate entry of the editing reagents into cells, they're loaded into nanoparticles, which are about the size of a virus. They're synthesized from biodegradable polymers. Most of our work uses polylactic co-glycolic acid, or PLGA, which is the material that Vicryl is made from. But it's possible to alter the core of the nanoparticle, the surface, and the size, and there's different biologic behavior depending on what you do with these particles. So before my arrival to Yale, my collaborators had noted that these agents were more efficient in blood stem cells than differentiated blood cells. And then we've subsequently demonstrated that the enzymes that drive this editing are upregulated in fetal liver hematopoietic cells compared to adult mouse bone marrow stem cells by RNA-seq. And so I used the technique that I learned in Alan Flake's lab, which is analogous to fetal blood transfusion that Tippy described, that can be performed clinically and safely under ultrasound guidance. Here you see an injection of green fluorescent nanoparticles into the middle and vein of the mouse at day 15. These injections result in remarkable delivery of nanoparticles into the fetal liver, as you can see in the top right. Of note, again, the fetal liver is the site of the hematopoietic stem cell before migration to bone marrow. And for lifelong correction of hemoglobinopathies, the hematopoietic stem cell is the ideal target for gene correction. We've demonstrated that these editing reagents grant reasonable survival, postnatal growth, and do not generate an immune response by a panel of cytokines. Our preclinical mouse model was beta thalassemia, where a point mutation in the beta globin gene results in severe anemia. Our experiment, the beta thalassemia mice receive IV injections of nanoparticles loaded with editing reagents specific for that model. This results in about 6% editing in blood with no measurable off-target effects in the homologous sequences. And that's not to say there are no off-target effects. There are no off-target effects in the places that we looked. The result is correction of anemia, where these mice in the middle genotype as beta thalassemia mice, but their hemoglobins are in the normal range, normalization of reticulocyte count, and improved survival. We also see normalization of the peripheral smear, so not normal, but improved. Beta thalassemia mice perform hematopoiesis in their spleens and develop huge spleens or splenomegaly. And so you can see that fetal gene editing results in improvement in the spleen size with the treated one in the middle, and improvement in spleen morphology. So clearly a lot of this work has been set back due to COVID for the year, but we've noted that we have improved editing with higher doses. And so one next step is that we are continuing to screen nanoparticles of different characteristics and compositions. I've left out the ones that really haven't worked. But this image represents IV fetal injections of green fluorescent nanoparticles followed by flow cytometry for fetal liver hematopoietic stem cells to see what percentage of hematopoietic stem cells take up these green particles. All the work that I just showed you were the 250 nanometer PLGA particles, which get into about 30% of the hematopoietic stem cells. And then we see that with smaller and smaller PLGA particles, we end up getting it into 80 or 90% of hematopoietic stem cells. In addition, these polymers in purple can be loaded at much higher doses with editing reagents. And so we anticipate that if more hematopoietic stem cells are accessed and there's higher doses of reagents, then we hope to have higher editing levels. And that's where I'm going to stop. Really, thank you, Tippy, for the opportunity to present here. I hope that I've demonstrated the promise of fetal gene editing for genetic diseases, some of the progress that's been made, and clearly there is a ton more work to do. Thank you very much.
Thank you, David, and thank you to all the panelists for a great session. I wonder if Bill and Diana, if you can just turn on your videos and we can have a discussion about the clinical translation. And from the attendees, if you have questions, please write them in the Q&A. I wanted to just start off by asking David, what's the path to clinical translation of this technology? Because it's, you know, the holy grail, of course, for hematopoietic stem cell therapy is to do it in vivo, and you've been able to show that with these nanoparticles. And so where does this stand in terms of the postnatal therapy and the pathway for to get into a fetus?
Yeah, so something I left out of here is that Saltzman and Glaser, my collaborators, have established these cells are effective in human cell lines. They were having the NIH kind of doing an independent assessment of these reagents. To date, a PNA has not been used in a patient yet. So I think that I have to wait until these are used in a postnatal patient. True Code, which was the company that had initially licensed this patent, had an interest in hemoglobinopathies and cystic fibrosis, and really wanted to wait until there was some postnatal data.
Mm-hmm.
So it's a long path.
Yeah, it is a long path, and I think, you know, I don't think it's that surprising that the FDA has said you need to test it first. You know, you need to only use something that's been approved postnatally, but it definitely, you know, slows down the pathway for some of these rare diseases that are also so severe. Bill, how about you? How about the pathway to clinical translation for the reagents that you've been testing?
So I think like you just alluded to, especially for gene editing technology, it needs to be demonstrated if you're going to do it in vivo, which is how we're planning on approaching any fetal gene editing approach. I think it needs to be demonstrated to be safe in a postnatal patient via an in vivo application. Right now, there's only one in vivo gene editing approach. All the other gene editing, CRISPR-based gene editing approaches are ex vivo for hematopoietic stem cells and that kind of stuff. So I think there's plenty of time, but I think you're laying the path is becoming more obvious, right? With your FDA approved enzyme replacement therapy, it now becomes more acceptable to treat these diseases before birth, and then if you can say that there's a gene therapy approach that's approved after birth for the same disease, it then becomes a more logical leap.
Mm-hmm. I hope so.
Yeah.
Farmer, any words of advice for us based on your extensive work with the FDA for the MOMS trial and for the stem cell therapy you've developed?
Yeah, so I don't think we should give up. I think that we should make partners of our friends at the FDA and help them understand the importance of doing this work in the fetus. And I was really impressed with Vasum's conversation and what they have done with on the device side of the FDA, developing these programs and sort of expanding the ecosystem for children for devices. I immediately thought he needs to expand it for devices for the fetus, but I think we need to get into the cell therapy, a similar kind of process in the cell therapy and the drug development side for fetuses, because otherwise it's too slow. And as you Bill also pointed out, the chance for a lifelong cure and the amount of money that saves the health system, not to mention the pain and suffering for the patient for a lifespan, is tremendous. So I think we should maybe reach out to Vasum and ask him, I don't know if they cross the aisle, in the FDA, the device and radiology guys talk to the drug guys as much, but I think there's a path. I think we should not accept no for an answer.
Yeah, I think you're right. One of the organizations that's really helped us contact the FDA is CIRSE. It's the Center for Regulatory Science between UCSF and Stanford. And we're supposed to give an afternoon conference to the FDA on in utero gene therapy. So I think I'll be tapping some of you guys to be my partners in explaining to the FDA what an amazing unmet medical need this is, and how the risk-benefit ratio does make sense for some of these rare diseases and for moving fetal surgery forward in general. So
100%.
Well, thank you, everybody. Thank you for a great session. And I think we have a 10-minute break before the next one.
Yes, 10-minute break, 4:10, we'll reconvene. Thank you.
Thanks, Tippy.
Great to see you guys.
Great to see everybody.
Great session, everybody.
Well, hello, welcome back, everyone. We are now entering into the last few sessions of the symposium. Let me now invite Tenley Harrison to introduce our next speaker.
Good afternoon, everyone. My name is Tenley Harrison. I'm lucky enough to be Mike and Gretchen's second child. I'm also lucky enough and honored to introduce our next speaker, Dr. Esther Choo. Esther and I live together. Esther and I lived together our senior year of college, back when she was an English major. And she is now up in Portland, Oregon. She's a professor in the Center for Policy and Research in Emergency Medicine and the Director of Recruitment, Equity and Inclusion in the Department of Emergency Medicine at Oregon Health and Science University. She's a practicing physician, the co-founder of a company, Equity Quotient, and a columnist for The Lancet. She is also, according to my doctor's sister, a social media rock star who regularly puts her English major skills to work on Twitter, Facebook, and other media outlets, writing and speaking out about racism and sexism in medicine. In addition to all this, she's a mom to 4 beautiful kids and just an all-around smart, passionate, fun person. My dad appreciates, celebrates, and respects people who work hard, follow their passion and pursue big ideas. And so I know he joins me in welcoming Dr. Esther Choo.
Thank you, Tenley. It has been so special knowing that I'm probably the only one here who really thought of Dr. Harrison as the cool dad of somebody I really admired, and then secondarily learned about his science and his impact on medicine. I also wanted to say that as an ER doctor who only sees adults, attending today has been so moving. And I don't really know how to sum it up. I logged in this morning thinking I'd be in and out, but I've been attending every session. And just sending Tenley a lot of amazed emojis. And I think I just want to say that today has inspired me to be a good steward of your patients, knowing that you do so much to get them to live and thrive so that they can get handed off to me one day. I spend a lot of my time thinking about how to make the healthcare that we deliver, the research that we do, and the places that we work in much more equitable. And so that's what I'm going to be talking about for the next half hour. I may race through some sections. I do have my clock going, and I wanted to leave a little bit of time for questions at the end without keeping you too late into your day. So here's what we're going to do today. We'll talk about thinking comprehensively about how compounding factors lead to inequities. We'll talk about opportunities we have to influence equity through the research that we do, and then we will talk about how we extend equity efforts to our workplace in a more comprehensive and systematic fashion. So just to start with a clear and common definition, you'll see a lot of formal definitions of health equity out there, but I try to get it to a sort of phrasing that I can think of that is just at my fingertips when I walk into the hospital every day. What does it mean to enact health and equity? And to me, it means that every patient that I see walks in the door and feels that they were respected and cared for to the best of our abilities, and that feeling is statistically true across populations in terms of our health outcomes. And so when we think of health inequity, I've lately started to use COVID as kind of the exemplar for how inequity plays out, because there was no subtlety in the way that inequity has played out in this pandemic, and it's so top of mind for all of us. So I hope you're not too tired about COVID. But when I think of inequities that I study across health topics, it's sometimes like looking for that small odds ratio difference between two subpopulations. But for COVID, it was much more like from the space. You know, from space, looking down at Earth, I felt like you could see this grand inequity that played out, and it was something that we anticipated, saw very early on in the pandemic, and then every time we measured was more apparent. And I think you're probably familiar with these statistics, but over time, the cumulative COVID-19 mortality rates across racial and ethnic groups were very, very different, with Black and Indigenous Americans bearing the highest death tolls. This is another way of looking at it. These are age-adjusted mortality rates across different racial groups. And you can see that, you know, among some groups, Pacific Islanders, Latino, Black, Indigenous groups, more than 2 times the mortality rate of white Americans, even adjusting for age. And just a side note here, because I'll be talking a lot about kind of the research approach to equity, but you'll often see in studies that Asians and Pacific Islanders are clumped together because of low sample size numbers, but look what is lost. And when you separate out those groups, huge differences in the way that this pandemic played out. And we talk about, you know, why did these inequities occur? And the answer really is because of all the reasons. Everything that you can look at, every resource that we had in the way that this pandemic played out was inequitable based on race. And this started with testing. This was an early study out of Sutter Health System looking at who got testing in the ambulatory care setting. And if you were an African-American patient in that setting, you generally did not get access to testing early or in an outpatient setting. Really half as likely as white or Asian patients, you had to be sick enough to come into the emergency department or even to get hospitalized before you got your COVID test. We saw it in treatment, looking at, this is a cohort of cancer patients who were diagnosed with COVID-19. And when we looked at who received remdesivir, I wasn't a huge fan of remdesivir, but still as a marker of treatment, Black patients were about half as likely to receive remdesivir as white patients. Again, another half as likely, like the testing. And some of that certainly was up to individual physicians, but there are also structural causes, as there always are. If you look at where remdesivir went, it went selectively to hospitals, and often hospitals which had more underrepresented minority patients. Those hospitals seemed less likely to get supply of drug too. So always individual and structural factors. On to vaccine studies. This is the published study for the phase 1 Moderna trial. And if you looked at that table 1, those zeros just kind of tell the story of their own when you look under race or ethnic groups. And it particularly hits hard to see all those zeros or single digits among racial and ethnic minorities, because we know who was disproportionately affected. And of course, Moderna corrected this through in their phase 3 trial. But I think, as we look at vaccine distribution, we're still seeing the same inequities. Again, even though Black and Latino groups were affected the most by COVID-19, much lower receipt of COVID-19 vaccine to date. This is all of March, as of March 23rd, and this represents the data from 34 states in the District of Columbia that have some race and ethnicity data. I will say, even of the states that release data, about 24% of vaccine recipients do not have racial background specified. So we're still missing a lot of data, but we suspect that as racial and ethnic data come out in vaccine distribution, just like it did in testing and case rates and in hospitalizations and deaths, we will see actually further disparities based on race and ethnicity. And I will say, when we don't include populations in studies, that is something that affects the success of these vaccines. So this is data from Kaiser Family Foundation, and they said that confidence was directly related to the sense that your ethnic or racial group was well represented in the COVID-19 testing. So I really do think that early lack of inclusion in phase 1 studies created a downstream effect in terms of vaccine success. So it wasn't just that, inclusion helps us know that the vaccine is effective across populations. There's also simply the effect of not including people in that they understand that they were not thought of when we developed the science. So kind of putting all these things together, I will say, I thought a lot about inequities kind of in piecemeal, and COVID-19 really made me think about what is our framework for thinking about inequities comprehensively. And during the pandemic, this is kind of the way that I thought of things. I thought, everybody came into the pandemic with different with differences at baseline in terms of their social advantage. And those things tend to be determined by things like race, ethnicity, but a host of other factors: sex, gender, your gender identity, sexual orientation, disability, religion, your country of origin, language, age, a whole host of factors, where you live, where you grew up. And all those things fed into what happened during the pandemic. They determined disparities in exposure to disease, in your susceptibility to contracting disease and disease severity once you were exposed. It affects your receipt of healthcare, and affected who we enrolled in clinical trials, and therefore our knowledge base and our ability to treat people as we move forward. And there are so many examples of each of the ways that each of these disparities played out. I mean, if you just take disparities in exposure to disease, everything that affected that is differential based on some of these factors like race and ethnicity and socioeconomic status. So just think of who was the essential workforce, who predominated in these essential workforce roles, who had fewer work from home options, who was using public transportation as opposed to traveling in private car, who were the sole wage earners of their families and lack sick leave, and so cannot take time out when they are exposed to COVID-19 or even when they get sick from it, who lives in multi-generational or crowded living conditions and cannot actually isolate or quarantine effectively, and then who's in caregiving roles. All those things differ based on some of these social factors. So basically, these things compound, they're additive or more than additive, and lead basically to the disparities that lead to unequal rates of illness and death. And of course, in our positions in healthcare and in research, we don't have a lot of power in our regular workday to affect the upstream things. And I think this is generally where we have ability to have impact, and it feels often too downstream to reverse some of these things. And yet there's a lot that we can do. So just taking that downstream place that we occupy, I think again about patients coming to us with these baseline differences, and then here are the things that we have power to impact. You know, what are the inaccurate constructs that we sometimes apply to health and disease for our patients? How does that lead to biased clinical practices and algorithms? How does that lead to biased research and innovations, and also applications of the innovations that come out of our research? And then what are ways that as individuals and within our systems, we reinforce existing constructs, practices, inquiry, and innovation? And again, all those things, if we do not combat them, ultimately lead to unequal rates of illness and death. So let's get a little bit more specific. What am I talking about when I talk about the way biases can be built into our research, into our structures, our systems, and our individual practices? So you may have seen this come out at the end of last year in the New England Journal. This was a correspondence, basically a brief report that came out of the University of Michigan, in which researchers obtained paired measurements of oxygen saturation, comparing pulse oximetry and arterial oxygen saturation directly measured from the arterial blood gas in two cohorts. One cohort was from the University of Michigan. There were over 10,000 pairs obtained from over 1,300 white patients and 276 Black patients. And then there was a multi-center cohort of over 37,000 pairs. Again, with white patients and Black patients. And this is what they found. So you can look at the x-axis is the oxygen saturation as measured by pulse oximetry. And then on the y-axis, you see the arterial oxygen saturation. And you can see for a given oxygen saturation, so if you look at, say, 90% oxygen saturation on pulse oximetry, the red bars are Black patients and the white bars are white patients. So what they found was that for any given oxygen saturation on pulse oximetry, there was an underestimation of the arterial oxygen saturation, not in all patients, but much more likely in Black patients. So this is called occult hypoxemia, and they found that that if you looked between 92 and 96% on pulse oximetry, the arterial oxygen saturation of less than 88%, that was their definition of occult hypoxemia, was found in 11.7% of Black patients and only 3.6% in white patients. So, you know, it could occur in either Black or white patients, but much more common in Black patients. And they found similar things in the multi-center cohort. 17% of Black patients had occult hypoxemia and 6.2% of occult hypoxemia in white patients. And of course, you know, in this study came out as we were still at the, you know, in many places in the country having peak rates of COVID-19 patients. And right at that level, that differentiation around 92% to 95%, that's where we made the decision to keep patients in the hospital for supplemental oxygen or send them home. So we thought this could also be something that, you know, was built into our systems that could make a difference in outcomes for COVID. And their conclusions were reliance on pulse oximetry to triage patients and adjust supplemental oxygen levels may place Black patients at increased risk for hypoxemia. There have been, one side note, this is the composition of their team, and this doesn't have to do with race because you can't gauge race from just names, but I will just say, having just come out of study sections, I am often amazed at the number of all male teams, and that's true for the next study I'm talking about too. And I would just say, as a side note, if you have more of one name, of one male name, than you have women, that's probably like a good, you know, big picture guideline to use for your study. Could use a little bit more diversity of some kind. So this is an earlier study, from 2007, this time looking not in hospitalized patients, but in healthy volunteers. But they brought in 36 healthy volunteers who were adults, and they applied a face mask with an admixture of air, nitrogen, carbon dioxide mixtures, and then also placed a radial artery catheter for serial arterial blood measurements. And I love this disaggregation by specific race and ethnicity categories. And what they looked at was across 3 different manufacturers of pulse ox, of finger probes for pulse ox. they looked at how they performed at different levels of oxygen saturation, and this was a little bit, I guess, a finer look at what skin pigmentation does than the last study, which was really just binary: were you black or were you white? This looked across a range of skin tones, and it basically showed there was a suggestion that there was kind of a continuum. So there was more bias, meaning the difference between your pulse ox and your arterial blood measurement. If you had very dark skin, and then if you had darker skin, but it was lighter, it was kind of in the middle. It was kind of intermediate in the terms of the amount of occult hypoxemia, and then light-skinned or white subjects are the open circles and tended to have the values that were closest to the arterial measurements. And so what they found in general was that occult hypoxemia was noted once again, especially with increasing hypoxia. And it appeared to have a continuous relationship with skin pigmentation. They also found in the study that gender also tended to affect the accuracy of the pulse ox measurement, although that was probably related to low hemoglobin. And then they found a lot of variability across oxygen saturation ranges, the manufacturer itself, and also the clip-on versus adhesive probes. And so the conclusions from this were that, first of all, it's important to consider device bias in clinical decision-making, and also that results from one device cannot be generalized to all devices. So we can't just have that, one study or one manufacturer that looks at the potential impact of race or gender. Everybody needs to consider these things and really make sure that their study populations are representative, and also that that studies need to really consider what a broad range of things that could impact the device performance. And I think the other thing about the study that I walked away with was that it was a really good prompt to consider what exactly we are capturing when we talk about there being racial or ethnic differences. I mean, this is so literal. We're talking about skin tone, but I think often we just throw in race and ethnicity as a proxy for something that actually can be better defined. Maybe it's skin color, maybe it's the impression somebody has when you walk in the door, maybe we're actually talking about body mass or something like that. And I think we tend to just say there's differences by race and not articulate what exactly is leading to the differences in clinical outcomes. There are, of course, so many examples of this across devices like spirometers, but also across clinical calculators like EGFR estimations, algorithms for working up UTI in young children with fever. The spirometer one, I'll just point out a couple of things. One is that when we ask about race, we often treat it like a binary thing. So in this study, they recruited patients to take spirometry measurements and asked them what their race was. And for patients who said they were African American, they did genetic testing and were able to actually give a percentage of African ancestry that they had. And they found that if you look at the top lines, they found that these are all people who, in most studies would just be Black. They would just fall under this big lump sum category. But actually there's a lot of heterogeneity in what that means for you in terms of your actual genetics. And they found that the greater percent of African ancestry indicated by your genetic testing actually correlated in a linear fashion with your spirometry measurements. And if you look at the bottom two slides, these are all patients that would have gotten a binary, kind of a set racial correction in our spirometers, but there was a wide variation in what their genetic testing suggested should be incorporated into their spirometry testing, and what was actually reflected based on their genetic testing. So all this to say that we often make these observations about clinical difference based on very broad race or ethnic categories, and then we stop there. When we create clinical algorithms where we say, well, you add 2 points or you multiply by this if you are African American or if you're Hispanic or if you're Asian, but really racial and ethnic observed differences should just be the beginning of our curiosity about what the etiology of these differences are, rather than just committing to treating these factors as kind of binary factors in major clinical decisions. And so the authors of this study and also the associated commentary suggested that noted differences should really lead to a process of investigation of specific causes of difference, whether it's physiologic factors, environmental factors. Sometimes when we're talking about lung function, it could be things like occupational segregation, or are we really talking about ancestry? And then what do we do with people who have a certain proportion of ancestry from a common place, and so on. And I think ultimately, if we're really talking about ancestry, we want to get to mapping and identifying gene variants and really treating people like individuals rather than treating them like they are part of a kind of monolithic group. A couple side notes. First of all, I think there are ways in which we can influence our environments through research simply through the language that we use. And I will just point out that we still have programming and equipment that has outdated language and labels like master and slave. Those we have not managed to purge from our hospitals. I understand that these can be reflective of a historical relationship and not meant to be race-based. But imagine what that kind of language means to patients who hear that and hear us refer to that, especially since we don't live in a historical context. Another side note is that it is very helpful to question the underpinnings of our individual biases. So something we talk about a ton in emergency medicine is our racial bias in the treatment of pain. This has been incredibly well documented, even among pediatric patients, even among patients with very specific conditions like appendicitis or long bone fractures, where we all agree that pain medication should be given generously. And this is a study from the Proceedings of the National Academy of Sciences that just asked a sample of people, first an online sample of non-medical people, and then medical students and even residents about their beliefs about biological differences between Blacks and whites, and a lot of Black and white individuals. And the responses really suggest that when we treat patients differently, even among medical trainees, we have some very disturbing underpinnings about the differences between people based on race. So this is something that was fairly common in the online sample. This is a count out of this, sorry, you can see that the counts are highest among the online sample, but still persist through medical training and on through residency. This one too, again, this was done in 2016. So these ideas, these racialized concepts are still common. I think people probably don't vocalize them, but when we trace back from the way that we are treating people, when we are designing clinical research, when we're designing protocols, and when we're looking at outcomes, I think sometimes we really need to question the theoretical underpinnings of our behaviors and our structures in healthcare. So what do we do for all these things? It's hard to sum up in a short period of time, but I would say these are some of the things that I think you can gather from what I've presented already. I think we need to consistently scrutinize the underlying assumptions behind our research. We need to create and uphold standards for representation in studies. I know we all fill out enrollment tables, but I also know that we're often not held to them. Or asked to rationalize why we were not able to meet our enrollment expectations that we had planned. We need to approach race and ethnicity with specificity and make sure that we know what our hypotheses are for differences that we find in these groups, what they mean for our study, for our innovations, and how we know that we have accounted for them and that we're treating those categories responsibly. And I think we just need to have a lot of curiosity about potential inequities downstream of all our new innovations. A couple of other things that I think we need to apply broadly and consistently. We can all do a better job making our equity efforts systematic, comprehensive, and advanced by everyone that we work with. We can also bring an equity approach to all our studies, not just the ones that are specifically about health disparities or inequities. And then I think part of addressing health inequities is actually building organizations that internally reflect principles of equity. I was alluding to that a little bit with my observations about study team composition. But I think these are things that we can all play a role in and would make a big difference in the science that we put out and the care that we provide. And so just to go into each one a little bit more and give you some examples. When we do equity interventions, we're often very sporadic and not very thorough, and yet inequity creeps into everything. And so I think there's nothing that we do from the culture that we build, who we recruit in, how we promote and retain people, how we allocate mentorship, the way that we give education and training, of course, the way that we plan and conduct research, the way we do outreach to communities and ensure enrollment in studies, and also the way that we establish goals and metrics. All of these things, basically everything that you touch, down to the lunch you order, has an opportunity for improved equity. These are from my research center. We have a live document that is shared with everybody in my center. I created it, but I don't own it. Everybody owns it. You'll see the latest draft is from the end of March. There's not a week that goes by that someone doesn't touch this document and improve it. And these are kind of the domains where we want to do concrete things around equity. The document starts with priorities for the upcoming month. You'll see we have a bunch of subcommittees planned, and you'll see all these different initials by them. And that is because everyone in the center is expected to participate and take ownership of something. Every single person is a leader of our equity efforts. So I don't own it. No one person owns it or can drive it because everyone needs to be involved. Otherwise, the culture doesn't change. And that's the expectation that we've set up. And we also try to be very specific about what our beliefs and values are and where we are headed in this process. So I will say that just creating this document was a tremendous learning opportunity for our center. We realized there was a lot that we didn't understand. We have an extremely steep learning curve. We're still developing even just the language around equity and deciding basic things like what are the metrics so that we know that we are an equitable institution in our center. But it's something that I could not recommend more highly. The second thing, of course, this maybe should have been the first thing for a bunch of researchers, but really thinking about how equity is applied to all our studies in a very systematic way and something where we can feel it immediately. So this is a framework that we're applying to all the studies that we do, and we're trying to apply it to every grant application that we put in. And I don't expect you to read all that, especially on the right side, but concentrate on the left side because we're trying to think through systematically about, okay, if we're doing studies that really are equitable and think about the impact of this science on a very wide range of populations, shouldn't our study team itself be representative, as diverse as possible? So we think about just the composition of our study team, especially as it relates to whatever topic it is that we're studying. And then we think about our study design and how it incorporates examination of potential disparities, including how we calculate sample size and power to measure between group differences. We think a lot about data accuracy. So how are we defining race and ethnicity? In the ED, a lot of studies actually are really flawed because the way that we define race and ethnicity is the registration person when you walk into the ED just looks at you and then listens to you speak, and that's how they define race and ethnicity. And when we discovered that, we realized that it was like many thousands of studies from the electronic health records have been done out of the emergency department with that kind of race and ethnicity data. And actually we need to do a lot more to validate it. Race and ethnicity, of course, are often have a high degree of missingness, particularly with claims data and other large data sets. So there are many procedures we need to verify or at least to impute those values so that we can have a more robust data set and feel more confident in our outcomes related to these categories. Often we don't even power studies so that we can answer basic questions related to underrepresented group, and we make it virtually impossible to disaggregate data by racial groups. So you'll see many studies that actually will treat the race category as white and non-white, which tells you virtually nothing. And of course, there are issues with enrollment, including how we select inclusion and exclusion criteria. And I actually, in the interest of time, will charge past some of this. But just to say that there is a structured and comprehensive way to plan studies so that we are really having an equity orientation. And I think these things improve every study that you do, so that later you don't have to wonder if your outcome is because it works in some of your study population and not other. If you're considering subgroups ahead of time and being really thoughtful about potential causes of heterogeneity, it saves a lot of time and future studies. I think there is so much good literature out there to guide us now in evaluation, reporting, recruitment, and enrollment strategies. This document from the FDA is something that I use to just walk through different causes of lack of enrollment of diverse populations, and I found it tremendously helpful in terms of strategies as well. The last thing is to institute organizational change, and this I don't take lightly. I will just say that when we talk about wanting greater equity and really wanting to be representative, and then you walk through the halls and this is what you see, there's just a disconnect. And I will just say, it's okay. I understand why it is. Medicine is very traditional. In terms of organizational change, we tend to have slow progress. We don't have very much data about what helps us change and be more equitable and inclusive. We also don't define very clear targets, and we do interventions like kind of a shot in the dark without clear outcomes. For all these reasons, I started a company with a friend who also was very disturbed about the way that we approach equity as if we just kind of pluck interventions out of the sky. And I think the popularity of things like implicit bias training is one of those things where we don't have a lot of data about whether it works, when it works. And yet institutions spend a lot of time and energy making sure everybody goes through. So the point of equity quotient is just to quantify culture, particularly with regard to equity of all kinds, and try to guide institutions so that they're more focused about what exactly is needed for cultural change in order to achieve equity. We try to guide prioritization of interventions because you can't do everything all at once. And we also we create and track metrics over time so that organizations can assess the success of chosen interventions. Maybe you needed mentorship programs, or maybe you needed implicit bias training, but do you know that that is what you needed specifically? Or were those interventions not very effective because the actual issue in your institution that keeps you from maintaining a diverse body of employees is something entirely different? That is what we're trying to assist with. And just as in all of healthcare, it's very hard to change anything if we're not measuring it. So that's really our purpose. But I will give you a couple of universal recommendations across our clients. Just as a quick cheat sheet for you, we make very individualized recommendations after we do assessments, but I will tell you that these recommendations we end up giving to almost everybody. And they are to be more agile in making changes to try to improve culture. The number one thing that people who are not happy and are not being productive among in your workforce point out is often the lack of voice and agency in bringing up concerns and also being part of the solutions. We always tell people to listen more to your community because the best solutions are found there. People often feel that there is stated intent in even many written policies, but the execution piece and the clear outcomes are missing. And many people need to make a more concrete link between intent and impact. Also, almost nobody is able to state what their specific target outcomes are for improving equity in an institution. They're rarely measurable and they're rarely attached to timelines. So organizations that do that are really ahead of the curve. And then finally, communication and transparency are, I said, almost always in deficit. I would say they're always in deficit. I'd say that's a recommendation that we end up giving 100% of the time. So that's your free 2-minute EQ consultation. And so I would just end by saying, I started out with this definition of health equity in practice, and I will just add I think in practice, it means that we actively promote equity through our research practice and approach to organizational culture, knowing that we're really never done in this work. There's always more to do, but I think if we are intentional about it, we can make huge strides. Thank you for your attention.
Dr. Choo, thank you so much. Hanmin Lee here. Really appreciate the incredible work that you're doing, and I think as befitting the term trailblazing, you've definitely blazed a trail. We're a little past time, but I just wanted to ask, how do you really instill in every part of your institution the work of improving equity and not make it the job of, you know, a few people? Because that sort of doesn't seem like the pathway to success when a few people are driving this work.
Yeah, I very recently got a diversity job in my department role, and I actually avoided it for a long time because I think the issue with these roles is not that they're inherently bad, but they're often created as a way for institutions to avoid responsibility for things related to diversity, equity, and inclusion. And so I basically accepted the role under the condition that it was defined as a supportive role for the work that the department is doing. But I thought the actual work should be in the hands of all the department leaders. And it was their job to instill responsibility in everyone within their domain, their division, their center. So that was my condition. And so that was the way that our departmental leadership framed it, so that people wouldn't just be like, we've got this issue, can Esther handle it? Because that is just not going to lead to change. And I think that's actually the issue. And you see this around the country. Everyone now has all of a sudden has an equity inclusion officer. It's like the hot new thing to do. And I think it just can take, I think it removes responsibility sometimes and just creates this one person who's responsible for it all, which of course is not the way that anything is going to get done. So I think these positions should be well resourced, but I think every single person should actually be incentivized to do something in this realm. And that's really up to leadership to make it a concrete expectation and to build in, I think, you know, I mean, it can be a positive or negative reinforcement. I actually think, you know, I think carrots to do this work, financial incentives, promotion incentives should be built into this kind of work for everybody.
Well, thank you so much. Yeah, institutions need to put their money where their mouth is, right? Well, thank you. And we're going to turn it over to Mike to present the awards for the device competition from this morning.
Thanks, Hanmin. So Usha was going to put up, I want to start by thanking the people who put this fabulous day together.
Just a minute, Dinora is.
Okay. Well, you all know who is behind all this. It's Hanmin and his group of merry men and women. So it's Hanmin and Shubo, Rory, Usha, Tadeka, Liz Gress helped, my family helped, and Denora Moroda was particularly hardworking, and Vinith Johnson, Tenley, lots of folks. So thank you all. I wanted to put your names up behind me, but I guess it's not working. So next we get to move on to the awards, which are really fun. I don't know about the rest of you who are joining us, but my head was spinning all day from all these new things that people are coming up with. I just love it. Man, it'll just keep you awake at night for weeks. So I'll start by saying that first, there were like 60 applications to make the finals, and only 11 teams made the finals, and they were all so spectacularly good that I just felt sorry for the judges choosing some. Let's start with the mentorship awards, which is honorable mention, and that is Astio, the craniofacial folks, Limbics Health, the Behavioral Treatment Health, and Stanford University Cat Watch catheter EKG deal. Then I'll go, so I guess there's nothing to show behind me for this, Usha. Then we'll go to the Bronze Awards. So the Bronze Awards get $25,000 each, which is particularly useful for early stage companies. The 3 Bronze Awards go to Baby Steps Orthopedics, the clubfoot folks, Better Sleep Designs, that cubby bed thing, which was great, and Starlight Cardiovascular, the stents for the ductus venosus. Next are the Silver Awards. The Silver Awards, there are 3 of them, and they get $50,000 each. And the first one is Octus Surgical. They're clever treatment for scoliosis. I'm happy that spun out of here. Michael Labs and UCSF Surgical Innovations got the Benioff Children's Award, and Autus Valve Technologies. Hard to separate Autus and Autus. The pulmonary valve, the expandable pulmonary valve, which is very clever. Next are is the Gold Award, which is $75,000, and that goes to Rios. I hope I'm pronouncing it correctly. The folks who do the flow sensing over the cerebral spinal fluid catheters. And finally, the Platinum Award, $100,000, for which I should get some kickback, I think. It goes to Novonate, the folks who figured out how to keep the umbilical cord catheter from migrating and allowing access to the umbilical cord. All these things are just wonderful clinical contributions. And it's just inspiring to me to see how many good things are coming from this device innovation business, which was pretty much dead in the water 20 years ago and now is thriving. So thank you all for participating in the competition. And yeah, so is that it, Usha? Should we say goodbye? Thank you to everybody.
And
Yeah,
not
well,
yet.
we just have one last thing, Mike, and
Yes.
thank you. And for the groups, our Pediatric Device Consortium will be in touch about how to not only distribute the monetary awards, but how to do further mentorship for all the teams. And as Mike said, we had so many great devices and groups, and I suspect that we'll be hearing from some of the ones that didn't even make it to the pitch competition, because we really had a difficult time selecting those out. So finally, it's my pleasure to announce Matthew Cook. Matt is a native of Massachusetts, and in fact, a particularly special part of Massachusetts, Martha's Vineyard. So if any of you are traveling to Martha's Vineyard, Matt is the one that can tell you where the best fried clams and lobster rolls are on the vineyard. Matt got an MBA at NYU and worked for the Chartis Group, a healthcare consulting company, for nearly a decade. One of their clients, Children's Hospital of Philadelphia, liked him so much that they hired him as the executive vice president for strategy and business development. He did a spectacular job there and was subsequently then moved on to his next position, where he was president for Riley Children's Hospital, and Riley's part of Indiana University Health System, and he was the chief strategy officer for all of IU. We were very fortunate to hire Matt as our second president of the Benioff Children's Hospitals, both San Francisco and Oakland, where he leads our clinical strategy and operational team. So Matt, if you would, give us your impressions, and if you could sum up the day for us, and thank you very much.
Yeah, thank you, Hanmin. So I want to thank you for giving me the opportunity to bring the symposium to a close this year. I will keep my comments brief because I know it's late, and especially for those of you who are joining from other time zones. I also realize I'm standing between you and your weekend, and potentially a blind wine tasting, as mentioned by Dr. Diana Farmer in her tribute to Dr. Harrison today. Much like Dr. Julian Sosa's remarks, I feel like an interloper in the symposium, but it was an incredibly interesting day. It was inspirational to see the pitch and what ideas there were this morning, and just the level of creativity, as well as the progress that's been made on the artificial placenta and fetal molecular therapies. And I think it sends a powerful message to conclude with Dr. Esther Choo's talk on health equity and diversity. We clearly don't talk about these issues enough, and really the direction that we need to head. I want to thank the organizers for the rich content that was brought to life during today's symposium. Dr. Harrison, I think this is a testament to you about what the talent and the expertise it attracts on an annual basis. You and I have not had the opportunity to meet yet, Dr. Harrison, but as Dr. Lee mentioned, I spent some time in Philadelphia and had the chance to work with Scott Adzik and Alan Flake, and heard your name many times there. And now that I'm here at UCSF, the birthplace of fetal surgery, thanks to you, I'm really looking forward to working with Hanmin and Dr. Tippy McKenzie. I have to tell you, I was really moved by the story of your patient today, who's now a nurse in New York City. It's just what an incredible legacy you've created. Today was about creativity. It was about entrepreneurialism. It was about perseverance and about resilience. And it was all for kids. Chancellor Sam Huggood talked about the importance of innovation this morning, and by extension, the Pediatric Device Consortium. As you know, we give an award, and so this is very important to us, and we will continue to wholeheartedly support these efforts. Another takeaway that I had today is the importance of collaboration across the industry, as well as with the FDA. I think if we're going to continue to improve the lives of children, then this cooperation is essential to speeding up the development and commercialization of innovative approaches to care that we heard about. So let me close with asking all of you to continue your efforts for kids. And as we finish up today, let's give a warm round of applause for Dr. Harrison, as well as the symposium organizers. Thank you, and have a great weekend.